Day 2, welcome back to the November 5th or 6th, 2025 board meeting. My name is Sung Oh, President of the board. Before we convene, I would like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with our interests with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. As the agenda details, the board has significant business to complete today, including significant business to complete today. Luckily, we did complete all the time-sensitive closed session items, and to ensure the board, bless you, our treasurer Chandler, to ensure the board has sufficient time to complete all of its necessary work, I have advised the meeting moderator to allot 3 minutes to each individual providing comments. We'll begin with public comments for individuals attending in person, in Anaheim, followed by public comments by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I would like to ask staff moderating the meeting to provide general instructions. I believe today is Shelley again.
I am back.
Okay, thanks, Shelley.
You're welcome. When public comment periods are open today, if anyone would like to make a comment, please click on the hand icon, which is typically located at the bottom of your WebEx screen. If you're on a mobile device, you may need to click on the ellipses or 3 dots to access the hand icon. And if you are a calling user, you can press *3 to raise your hand and then again to lower it. Instructions will be on the screen when we open public comment. I will call each person by their name and send a request to unmute your microphone. Each person will have 3 minutes to speak, and we will be providing a 10-second warning. We will also be displaying a countdown on the screen. Our call-in users can press *3 to raise their hand, as I mentioned, and then *6 to unmute their microphones. We will attempt to call on people in the order in which they raise their hands. And again, we are asking everybody to only speak 1 time per agenda item today. And I'll turn the floor back over to President O.
Thank you, Shelley. I would also like to remind individuals participating in the meeting via WebEx that consistent with the board's policy and with implementation of the board's new learning management system, pharmacists and pharmacy technicians attending the meeting via WebEx today may be awarded up to 6 hours of CE. Please review the information on the agenda and follow the instructions provided to ensure you are eligible. You'll be required to register through the board's learning management system, PharmEd. And also, I'm happy there's few attendees, so make sure you collect your CE. 6 hours per renewal cycle is my recollection. So that's a good number of CE to earn. So hopefully you stay for the whole meeting. I would like to take a roll call to establish a quorum. Jesse Crowley.
Licensee member present. Do you have to read off the screen as well? One moment. And there are no other individuals 18 years or older present with me in this room at this time.
Jesse, you sound a little soft, also a little robotic-y, just a heads up. So hopefully that gets resolved.
Okay.
Trevor?
Present.
Thank you. Renee?
Licensee member present.
Thank you, Renee. Jeanette Dong?
Public member present.
Thank you, Jeanette. Jeff Hughes is not joining today. KK Jha?
Licensee member present.
Thank you, KK. Claudia Mercado? Claudia?
Present. And there's no
Thank
other
you.
individuals 18 years of age or older are present in the room with me at this time.
Thank you, Claudia. Jay Newell?
Public member present.
Thank you, Jay. Ricardo Sanchez?
Present public member.
Thank you, Ricardo. Satinder Sandhu?
Licensing member present.
Thank you, Satinder. Maria Serpa?
Licensee member present, and there are no individuals 18 years of age or older present in the room with me at this time.
Thank you, Maria. Nicole Tebow?
Licensee member present, and there are no other individuals 18 years or older present with me at this time.
Thank you, Nicole. And I am here. A quorum has been established. I truly appreciate everyone's time and commitment to the board and California consumers. Again, we have a very full meeting, as always. I ask everyone participating today to be respectful of the work before the board. We encourage participation by members of the public throughout our meeting at appropriate times. The board respectfully requests that when comments are provided, they're done so in a professional manner consistent with how board conducts its business. And before we move to the next agenda item for the day, I would like to remind board members participating via WebEx to please remain visible on camera throughout the open portion of today's meeting. If you need to temporarily turn off your camera due to challenges with internet connectivity, please remember to announce the reason for your non-appearance when you turn off your camera. I know there's somebody raised their hand on WebEx, but just a friendly reminder, we are not doing public comment today on items not on the agenda, as that was yesterday. So we're getting started with our first item for the day, which is agenda item 9, discussion and possible action related to proposed amendment to California Code of Regulations, Title 16, Section 1708.2, related to discontinuance of business, including review of comments received during the third 15-day comment period. Members, the meeting materials include background on the rulemaking package initiated by the board to amend Section 1708.2 related to discontinuance of business. You'll note from the meeting materials that following initial adoption of the regulation text, the Office of Administrative Law, OAL, requested that the board further clarify language. The changes requested by OAL were consistent with the board's policy and generally reward language and restructure the text of the regulation. The requested changes did not alter the requirements. Consistent with the direction from the OAL, staff initiated the 15-day comment period, which ended on October 22nd, 2025. No comments were received during this additional comment period. In addition to the cover memo for this agenda item, the modified regulation text is provided, as well as historical version
I'm sorry, we can no longer hear you. Is that just me or is there
Ah.
something going on in the
No, I
room?
couldn't either.
Okay. I heard unmute. Okay.
All we heard was historical versions and that's it.
Okay. I'm just gonna let's look. So I'm just gonna restart there. In addition to the cover memo, the modified regulation text is provided, as well as historical versions of the proposed text noticed throughout the rulemaking. Action is required by the board today to complete the rulemaking record. This was started in April 24th of 2024, so it was not as long, but still long, but we're almost here. So you'll note there is a possible motion which is included in the meeting materials and displayed on the slide. And so, members, I welcome your comments and also entertain a motion if you believe such action is appropriate. And I note that is Jennifer on, Robbins? Our regulation counsel is available as well. I think she's on, but
I'm on,
my
yes.
WebEx thank you, Jennifer. My WebEx got disconnected here. So I'm gonna have to rejoin that. I guess the hotel Wi-Fi is a little rocky. All right, members. I'm not joining the WebEx. My internet's down. We need a motion, members, not to put anybody on.
So you can't
I'll
see
make
your
a motion.
hand?
Maria.
Sorry.
Thanks, Maria.
And I can second that.
So let me read it. I'm sorry. I guess you can't see our hands, so I'm sorry.
Sorry,
to
I'm
ratify the
having a
mod-
little technical
That's okay.
difficulties here, so I'll
Move
join.
to ratify the modifications to the regulation text published during the third 15-day comment period from October 6, 2025 through October 22nd, 2025, and direct board staff to take all steps necessary to complete the rule-making process.
Thank you, Maria. And Claudia, you second?
Correct.
Sounds good. Members, do we have any other comments before we go for public comment? Seeing none. I don't have Jesse on the screen, so I can't see, but I think we're good. Oh,
I think we've
Get
lost
all
Jesse. I don't
Yes,
see
we
her.
lost Jessie. I'm watching for her to rejoin.
God, you know, year 2025, still having technical difficulties. Story of our lives. All right. Well, I think we're gonna go for public comment. I think that's benign. So we're gonna go for public comment in person in Orange County for this agenda item 9, discontinuous business regulation. Nobody is here to walk up, although our room is relatively full, so I'm very happy. Thanks for coming, all of you. We're ready for public comment in WebEx.
All right, if you'd like to make a comment on this item, please raise your hand. You can locate that hand icon at the bottom of your screen, as mentioned earlier. You may need to look for the 3 dots if you're on a mobile device. And if you're calling in, you may need to dial *3. Give just a moment for individuals to chime in and raise their hand. And not seeing any requests, I'll turn the floor back over to you.
Thank you, Shelley. We're ready for vote. Jesse's not on. So we're gonna go to Trevor.
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. The motion passes. Next, agenda item 10, discussion of proposed changes to application questions for individual licenses and possible action to initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1793.5, related to pharmacy technician application. As included in the meeting materials, the federal Lorna Breen Healthcare Provider Protection Act was enacted in March of 2022 to address mental health challenges faced by healthcare professionals. The act included several components with the goal of reducing stigma, enhancing support systems, and ultimately improving the well-being of healthcare workers. By way of history, the board previously considered this issue and agreed the board should update its questions consistent with best practices. Subsequent to this direction, staff initiated changes and sought review and feedback by the representatives of the Wellbeing First initiative stemming from the act. Staff received feedback and additional changes to the questions were recommended. With this additional feedback, staff can move forward to update the questions on several application forms consistent with this feedback without formal action by the board, as we already formally approved that process. But today for our consideration are proposed changes to the pharmacy technician application, which is incorporated by reference in section 1793.5. Given that the application form is incorporated by reference, the formal rulemaking process is necessary to update the application form. You'll note that in addition to changes to the application questions related to mental and physical health conditions, staff are recommending additional changes to the application that are non-substantive, seeking to remove instructional language in the application form itself in favor of including such information in the application instructions, as well as updating the educational affidavit to provide clarity and ideally reduce deficient applications stemming from possible confusion. The revised application also reflects the updated questions regarding mental and physical health questions. I do believe the general feedback is technician application has pretty high deficiency rate, so I would also like to welcome any feedback that would be easier for the applicants to follow along. Included in the meeting materials are changes to the application form. While I note it looks like a significant number of changes, I do agree with the recommendation from staff regarding the non-substantive changes. And of course, as well as changes with the our questions that are being asked related to the mental health stuff. So included in the meeting materials are changes of the application form. And so hopefully members, do we have any comments, any questions, concerns? I see Jesse's back. That's good. Need a motion though to propose a rulemaking. So if anybody is willing,
Hi, President O. This is Nicole. I have a comment.
go ahead, Nicole.
I'm struggling with the recommendation to remove any kind of reference to like having substance use disorder treatment or alcohol treatment or something. I'm kind of afraid that that first question, people are going to miss that that's the meaning of it. So I almost feel like we do need that second question that they recommended removing, or that we add something to the first question that's like including substance use disorder or alcohol treatment, or, you know, something like that. Because I feel like it's going to be missed. And I feel like I get their point about not wanting to discourage people from getting treatment, but at the same time, we work with drugs all day long. So I do feel like this is relevant. I don't know if anyone else is having that struggle, but I didn't love removing that.
Okay, great comment. That's why we have it here. So thank you, Nicole. Trevor?
Yep, I will just second Nicole's remark, especially like as someone in the recovery community. I think the best way to prevent problems is to make sure that everyone is fully aware of that sort of risks that are involved. And I think it can be done in a way that is not discouraging. We want to encourage people that are a part of the recovery community and that have made those positive changes in their lives to feel comfortable in applying, while also acknowledging the very kind of obvious challenges that are there as well. So I would support something that navigates that in that delicate way that again doesn't discourage people that are in recovery, but also makes note of the challenges there.
Thank you, Trevor. Any other member comments? So this is just initiation. So I think we do, if the members are agreeable with the sentiment that Nicole's sharing, which is completely understandable, I think we can, go ahead, Trevor.
So I move to initiate a rulemaking to amend California Code of Regulations, Title 16, Section 1793.65, consistent with the board's discussion, to direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 45-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulation at section 1793.65.
Thank you, Trevor, for the beautifully read motion there. I appreciate that. Today, we're all going to compete for who can talk the fastest. So we're going to then seek for second. Do we have second for that motion?
I can second.
Thank you, KK. So I think that we're all agreeing with the sentiment from our member Barker is, member Tebow is raised. So I see Maria, your hand is raised. Go ahead, Maria.
Sorry, I just wanted to clarify, maybe with Jennifer and Trevor, that the motion that was in our meeting materials and posted is slightly different, and as long as it meets the needs of what Trevor read, he said, especially the last part, 17.93.65 is what I heard, and it says 0.5. So I just wanted to clarify.
Yes, the motion that Trevor read is more consistent, but I just want to clarify which section. If it's the one that you read from the paper, remember, Trevor, then is that one the one?
I think, go ahead.
If I could just kind of jump in really fast. So there's two regulations, or there's the next regulation that the board will be considering is 0.65. So I think maybe just pages got stuck together.
Yes. Yep.
So this section is 1793.5.
Thank you for catching that. Yes.
But it really would just need to amend. Trevor, let's make sure that for the record, you meant to say 1793.5.
For the record, I meant to say 1793.5.
And to confirm that our second, which KK is confirming that.
Yes, please.
Perfect. And members, so are we okay with that direction? Are we all following along? So staff will direct the update to include Nicole's and Trevor's comments and incorporate that and propose a rulemaking. I'm not hearing anybody dissenting, so we're good to go. Okay, we're ready for public comment. In person, please. I don't see anyone, so we're ready for public comment in WebEx.
All right, as a reminder, if you'd like to make a comment, please find that hand icon either at the bottom of your screen through the three dots or the ellipses, or for calling users, press *3. We do have a comment from Chasney Johnson. Chasney, I've sent a request to unmute your microphone.
Hello, my name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. I was really excited seeing mental health being covered in today's meeting. Being a daughter and granddaughter of nurses whose main focus is mental health, I thought it would be a great time to participate on this topic. Being a patient community, whether that's getting vaccines at your neighborhood pharmacy or being seen by a primary care doctor, I have witnessed, but I wouldn't say it has affected some mind games. For example, pharmacy technicians have taken tests to learn how to administer vaccines. When it's time to get the vaccine, the scheduled pharmacist is asking, which chair would you like to sit in when the seating is already arranged? When being hired at some pharmacies, their onboarding training shows you specific seating arrangements for vaccine rooms. On a health and wellness visit for yourself, you shouldn't have to worry about questions like that when there are standards that should already be in place so a patient can feel safer receiving care from a licensed personnel within a company. Thank you for letting me participate on this topic and have a great day.
Thanks for the comments.
And seeing no additional comments, I'll return the floor to you.
Thank you, Shelley. Okay, members, we're ready for vote. Jesse, how do you vote? Jesse?
Yes.
Oh, there you go. Trevor?
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo. Ricardo.
Yes.
Thank you, Satinder. Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you. And I vote yes. Motion passes. Okay, next agenda item is agenda item 11. Discussion and possible action to initiate another rulemaking to amend California Code of Regulation Title 16, Section 1793.65 related to pharmacy technician certification program approved by the board. Probably some of you, for you, it's like, didn't we just do this? But moving to the next agenda item, as included in the meeting materials, pharmacy law establishes 4 separate pathways to licensure as a pharmacy technician, one of which is certification by a pharmacy technician certifying organization offering an accredited pharmacy technician certification program that is approved by the board. As the statute does not specifically identify the acceptable certification programs, the board has regulations at section 1793.65 that identify the specific pharmacy technician certification programs approved by the board to allow for a required ongoing review of acceptable certification programs and to ensure compliance with requirements included in Basic Business and Professions Code section 139. The regulation section includes a sunset date, which is currently June 30th, 2026. That's why I said this is something we've done 2 years ago, because we just pushed that back from 24. So given the recent changes in authorized functions of a pharmacy technicians, efforts are undertaken by the Office of Professional Examination Services, OPES, were delayed. It is anticipated that necessary work will be concluded, however, not in sufficient time for the board to consider audit findings and also pursue a regulation change as necessary. Given this, the board staff is recommending a 1-year extension of the sunset date to ensure completion of a pharmacy technician certification program remains a viable pathway to licensure while the OPES audits are completed and considered by the board. I have reviewed the matter and agree with the staff recommendation. And members, I note that the meeting materials and meeting slide display a possible motion. There it is. Very lengthy motion there. So whoever wants to compete for today's, who can speak the fastest, I welcome your comments as well as if anyone wants to make a motion. Members?
All right.
There we go. Thanks, Trevor. Appreciate that.
I move to initiate a rulemaking to amend California Code of Regulations Title 16, Section 1793.65 as proposed. Direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 45-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulation at section 1793.65.
Thank you, Trevor. Do we have a second? Oh, thank you, KK. Just for the record, KK.
I can second.
Thank you. All right. Do we have any other comments from members? I know this is an easy one, but just in case. Okay, we're ready for public comment. In person. Seeing none, we're ready for public comment in WebEx, Shelley.
All right, if you'd like to make a comment on this motion, please raise your hand. Locate that hand icon at the bottom of your screen. If you're on a mobile device, find the three dots or ellipses, and for call-in users, you can dial *3. As a reminder, you will have 3 minutes. Our first comment is from Sean Kim. Sean, I've sent a request to unmute your microphone.
Good morning, board. My name is Sean Kim from California Pharmacists Association. CPHA fully supports the board's proposal to extend the sunset date to approval of pharmacy technician certification program to June 30, 2027. Extending the sunset will allow the board to review the OPES finding to provide time to PTAC, Pharmacy Tech Advisory Committee, to evaluate the changes in context of AB 1503. Ensuring the uninterrupted access to approved certification pathway preserves the workforce continuity and the patient access to the care, and most importantly, their safety. In addition to this proposal, CPHA also recommends that the board to consider pharmacy technicians' continuing education regarding PIC-related responsibility to clarify their roles and responsibility and provide the accountability for both PIC and the pharmacy technicians under AB 1503. Thank you so much.
Thank you for the comments, Dr. Kim.
And seeing no additional questions, I'll return the floor back to you.
Thank you, Shelley. All right. We are now ready for vote, members. Jesse, how do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. The motion passes. Okay, next agenda item is 12, Enforcement and Compounding Committee Report. I will turn the meeting over to our chair, Maria Serpa, chairperson for the Enforcement and Compounding Committee. The floor is yours, Chair Serpa.
Thank you, President O. On behalf of the committee, I'm pleased to provide the board with a summary of the committee's efforts at our October 16th, 2025 meeting. Thank you to my fellow members, Vice Chair Renee Barker, Jeff Hughes, Sung Oh, Ricardo Sanchez, and Nicole Tebow. First item A is summary of presentation on board's outsourcing program. Members, background information on this agenda item is provided in the meeting materials. During the meeting, Dr. J.K. Fujimoto, supervising inspector for the board, provided an overview of the outsourcing program, including board licensure requirements, a comparison of 503A versus 503B facilities, types of drugs compounded, and information on outsourcing inspections conducted by the board. Dr. Fujimoto also spoke about how outsourcing facilities can provide patient-specific prescriptions. Members noted the important role of outsourcing facilities serve for hospitals in providing various compounded products for patients. The committee noted that post-implementation of the outsourcing program, there may be an opportunity for some possible changes to the law that may be appropriate to address at a future committee meeting. Attachment 1 includes a copy of the presentation. Members, do you have any questions or comments on the presentation?
Hi, Maria. Thanks for that. This is Renee. I I do want to just encourage anybody who didn't see the presentation. And since the full board is often part of the compounding discussion, it is very enlightening to just to see what the inspectors are doing for California consumers in inspecting these facilities. It's very complex. And I think we, to get their license there, or their out-of-state license. So anyway, I would really encourage people to look through those or listen to the entire presentation. It was excellent, and thank you to the staff who do those inspections.
Any other board comment? Thank you. And as a reminder, we do have some newer members on the board. Committee meetings are recorded and posted, so you can actually watch the presentation in addition to looking at the slides that are in the meeting materials. I think we're ready for public comment in Garden Grove. Anybody there coming forward? I can't see, so someone's gonna.
Sorry, Maria. There's no in person.
Okay. Moderator, we're ready for public comment for people participating via WebEx.
All right, if you'd like to comment, please raise that hand. You should find your raise hand icon at the bottom of your screen. For mobile users, you can find your ellipses to access it, and call-in users can dial *3. And seeing no requests, I'll return the floor.
Great, thank you. Members, unless you have additional comments, we'll move on to the next agenda item. Seeing none. B, summary of presentation on duty to consult and discussion of California Code of Regulations, Title 16, Section 1707.2. Background information on this agenda item is provided in the meeting materials. During the meeting, Deputy Executive Officer Julie Ansell gave a presentation on duty to consult, which focused on the value of consultation, associated regulations, barriers to consultation, and board actions that support patient consultation. The committee discussed if board current regulation requirements remain appropriate and considered barriers that exist to pharmacists providing consultation. Members were concerned that without reimbursement for consultation, it continues to be difficult for pharmacies to prioritize time for consultations. Members also expressed that it may be appropriate to consider whether current regulations might be amended to be less prescriptive and to empower pharmacists to use their professional judgment to determine what a patient needs to know and how they receive the information. Public comment similarly expressed the importance of consultation, that barriers articulated in the presentation are real, and that without proper reimbursement for consultation services, challenges will remain. Attachment 2 includes a copy of the duty to consult presentation. Members, do you have any comments or questions?
I do, Chair Sherpa. I just have, I'll go first. Sorry, I just saw your hand up, Jesse, but, so I think for me, I'm on the committee. So for me, I was lucky enough to voice my asks, but I just want for all the members to hear my 3 asks. So one, I think that it is important for us to consider as the public comment that was submitted for the written comments that was submitted, as you all saw, if there's a way for us to kind of look at ways for a pharmacy who really is not dispensing directly to patients, white bagging situations, that they would be actually clearly, be exempt from this requirement, because it seems to be a miss. I mean, I think practically, hopefully we're not doing really anything other than education, but I think it would be nice to make sure the regulations are clear, that it's not applicable, but also ensuring that that doesn't also, there's also oral consultations that we've discussed, the barriers and challenges. I think I'm really strongly pushing for, proactive consultations to be explicitly allowed. And a comment Nicole made during the meeting, how understanding that maybe a constant interruption could be a source of medication error, and we must consider that as a factor and hopefully find ways to allow proactive consultation and requiring maybe a documentation for those, and that would be okay in lieu of oral consultation. And as I voiced, I would like us to move forward with a more of a standard of care approach in terms of consultation instead of writing out exactly what must be done. And lastly, I think, our regulation does call out requirement when a prescription is mailed. I think that's okay, but I would like us to also look more into find ways to improve, not for pharmacies that, mail out one-off prescription and that they're open door pharmacy, but for pharmacies who are closed door pharmacies who primarily mail prescriptions and there's no way for patients to receive medication other than via mail. I want that to be a separate requirement where there may be more of an approach and requirement for them to actually reach out to patients for consultations and discussions. I think that would be my ask. I hope for that to be more of not just a piece of paper, how it is right now. I hope there to be more of engagement, higher engagement for patients via an app, electronic, however ways possible for patients to know that they're right to consultation. So that's my 3 asks.
I can't see everyone, so I think I see Jesse's hand.
Thank you, Maria. I wanted to speak more about like the barriers to consultation. So number 1, while I agree the consultation requirements need to be a little less restrictive, just from the patient perspective, I think it's really essential that we maintain the consultation requirement. I will say personally as a patient, I am almost never consulted on new medication, and I'm a pharmacist myself, so I'm okay with that, but that cannot be the standard. And unfortunately, what I see over and over again is that pharmacists are really in over their heads, and the pharmacist isn't even the one screening for the consultation. This happens to me over and over again, unfortunately, and I will say that the pharmacy personnel probably don't realize that I'm on the board of pharmacy or that I'm even a pharmacist. But I think it's really essential that we keep a consultation requirement. And I think there are a lot of barriers to that. I would be curious to see if the consultation violations occur more during flu season, because what we see, at least in the retail chain setting, is that we are being forced to take appointments, and we're being told to prioritize appointments for immunizations over filling medications. And so when you have 15 vaccines in a 15-minute period, it makes it almost impossible to consult the patient. And my fear of being less prescriptive, though, is that you're not really doing a full consultation in that time because you're worried about the next thing. I think there's a lot of factors here that are intricate, but overall, I think just from a patient perspective, we really need to make sure the core of consultation is preserved moving forward.
Thank you. Any other member comment before we go to public comment?
Yes, Chairperson Maria. There has been many there are many nuances in mail order and pharmacies that deliver prescriptions to the patient, like patients in ALF and independent living settings. And I think there are a little bit of, I think the presentation slide number 34 very adequately describes what they are. And that system, in my opinion, works fairly well. As far as retail is concerned, there have been many technological advances that has happened in how prescriptions are screened or not screened. So it may not be a bad idea to learn also from the industry that what kind of measures that industry has taken and put in to screen for patients who definitely needs more consultation than people who are, taking the repeat medications or refills. So I think it'll be a good idea in the future, if possible, to take some input from industry as well.
Thank you. I think that's an excellent idea. This was our first formal step into this area we've talked about over the years. And so we're looking at having an ongoing discussion in the committee to address this topic more formally. Oh, I'm sorry, Nicole, I didn't see your hand.
Oh, I just raised it. Thank you. This was mentioned already, but I'm just emphasizing it as well, that I think there needs to be some kind of exemption for drugs that are filled by a pharmacy but going to be administered in a clinic. We're seeing more and more of those with like long-acting injectable drugs around the consultation requirement. You can kind of treat it like a delivered or mail prescription, but it's otherwise very awkward, and you often don't actually get to interact with the patient in any way in those settings. So
Yes, thank you. And I wanted to acknowledge we did receive written comment on that specific topic. We talked about it during the committee, and everyone should have had the letter that came last week that reiterated that. That was Nicole's comment during the committee meeting also. Any other member comment?
I was going to make, Maria, one comment, short, but most of it has been said already. I agree that we should make it a clarification in specific setting where it's being prescription is dispensed to the provider, and the consultation requirement may not be the same in that scenario. And I agree the requirements needs to be there for consultation, but I propose as we move towards standard of care, I agree with the concept that it doesn't need to be prescriptive, because sometimes when you engage a patient, you realize they may know many of the steps that are already in the consultation. Then it could be more interactive and allows the flexibility of the pharmacist to assess what needs is important to be for the patient to know versus what they already know. That's all.
Thank you. Any others, or are we ready for public comment? I can't see Sung anymore.
Sorry. Yes, members are good, I think, and we're ready for public comment in person.
Any public comment in Garden Grove in person?
Yes, we do.
Good morning. Mic on. Good morning, board members. Lori Wamsley on behalf of Walgreens. I didn't have the opportunity to participate in the committee, but I certainly do appreciate this conversation. I think many of you know I serve on the Arizona Board of Pharmacy, not speaking on behalf of my board, but we're having very similar conversations. The environment certainly has changed, and patient expectations have changed. One of the things that my board has talked about is potentially changing our rules to allow for a pharmacy technician to make the offer to counsel and then also accept a decline, just because of some of the workflow pieces that occur. Oftentimes, when you're working in a pharmacy, a patient, the technician will say to a patient, the pharmacist will be able to consult with you about your medication, and the patient will say, I don't want to talk to the pharmacist. And that immediately puts a hold on the workflow. And that's one of the reasons why we've started talking about it, but really appreciate the conversation. I like the idea of allowing proactive consultation and look forward to the additional discussions on this.
Thanks for the comments, Lori. We have one more, Maria. Sorry, I keep thinking that you have camera angle from that side, and so I'm keep thinking we're in Sacramento room, so I apologize. I'm gonna do my do better about providing what's going on in this room. I'm sorry, Maria.
No, you're
Go
fine.
ahead.
Hello, board members. My name is Vincent Chires. I was not expected to comment on this, but since I am here, I do agree that maybe there should be some discretion with future technology in terms of consultation. However, at the retail setting, I'm a little bit more cautious. Already using the CVS app, you can activate your prescription. It will actually ask you, the patient, to clarify if your drug dosage has changed. And unfortunately, the app is still being used. There still needs to be additional safeguards because patients are still adapting, especially my older patients. So they're just clicking the blue button to get through so they can do a mobile app pickup to pick up their medication, not necessarily reading the warnings. So I will just express caution and when we talk about this subject further in the retail side. Thank you.
Thank you for the comments. I think that's it for the room, Maria. Go ahead.
Great. Thank you. Moderator, we're ready for public comment for people participating via WebEx.
All right, we have a few with hand raises already. It's just a reminder, if you'd like to comment, please raise your hand by locating that hand icon at the bottom of your screen. For mobile users, you can locate the ellipses, or for calling users, dial *3. And our first comment comes from Paige Talley. Paige, I've sent a request to unmute your microphone. All right, I'll circle back. Let's move on to, and I apologize for butchering the pronunciation of your name, Afruz Nikmanesh. I've sent you a request to unmute. You will need to click the unmute me button when it pops up on your end. Right.
Hear me?
Yes, we can hear you.
Oh, good morning. You did an excellent job on the pronunciation of my name.
Oh, great.
Shocking. Good morning, everyone, board members. I apologize. My connection is a little bit spotty, so I apologize if this has been talked about or addressed. As far as consultation is concerned, as somebody who's worked in retail for the last 28 years, and I've seen the evolvement, unfortunately, in the retail industry, I think it might be a good, nowadays we allow technicians to do a lot, including immunization. And I think that maybe incorporating, allowing them to ask the patient if they have, they can just, maybe present the medication to the patient and not just showing it to them. Something to the effect of asking the patient if they have taken the medication before, if they have any questions. Because what the requirement is right now makes it extremely impractical. And in the flow of the pharmacy, unfortunately, with most pharmacists, being under a lot of pressure and being understaffed, it basically creates more, I hate to say this, but more opportunities for mistakes to happen, or, taking the pharmacist away from matters that only a pharmacist can do. While a technician can simply ask a question, or a clerk can ask the question. It also creates a lot of frustration among patients, because they want to take their medication. I don't want to speak to the pharmacists, but the pharmacist is not available, so they have to wait there. The clerk cannot give out the medication. It creates a lot of unnecessary, in my opinion, work and frustration. So I respectfully ask the board, maybe you can consider, incorporating that, a clerk or a technician can simply ask the patient if they've taken the medication before, if they have any questions, and kind of get them involved in their, in participating in, what their medication is, what, changes have occurred. So that's all I had to say. Thank you for allowing me to speak.
Thank you. And we have a call-in user. Your number ends in 17. You've raised your hand. I'm sending a request to unmute your microphone.
Hi, good morning. This is John Gray. Can you hear me?
We can hear you.
Oh, great. Thanks. So this is John Gray, a registered pharmacist with Kaiser Permanente. So thanks for the opportunity to comment. Just a couple observations on this discussion. First of all, we fully agree with the board members' view. Many board members' view expressed related to the importance of consultation. Pharmacists are among the most accessible healthcare providers available to patients, and consultation is an excellent way for patients to access their pharmacist to make sure that they understand how to take their medications properly. I think on the discussion of whether there ought to be a forcing function, my words, for consultation by mail order pharmacies, I would urge the board to be cautious about that and consider whether requiring consultation, requiring an individual to engage in consultation is overly paternalistic, right? I think individuals have agency and should be able to make decisions about when and how they engage with healthcare professionals. So it would encourage the board to think about that. And then lastly, on the question of whether the regulation ought to be tailored to free up the pharmacist to select what ought to be discussed during a particular consultation. I think that's a great thing to pursue. I would also, I think, ask the board staff to look at whether the changes to Business and Professions Code Section 4051 under AB 1503 kind of already has already applied a standard of care to consultation, right? In my reading of the statute, the elements that the pharmacist needs to provide consistent with the accepted standard of care include providing clinical advice or patient consultation. And so it may already be that that a pharmacist standard of care would be the driving factor in what should be addressed during a consultation. And so perhaps the regulation is absolutely in need of update. Thank you very much for the opportunity to comment.
Thank you. Next comment comes from Sean Kim. And before I unmute your microphone, Paige Tally, I'm going to circle back around to you. If you still wanted to make a comment, please raise your hand again so that I know. Okay, I will come back to you after Sean. Sean, sending the request to unmute.
Good morning, board. I'm Sean Kim from California Pharmacists Association. We appreciate board's continued discussion of duty to consult and its real-world barriers. The presentation at the last board meeting was well delivered and very informative. Pharmacist consultation is one of the most effective tools to prevent med error, improve adherence, and most importantly, is building the relationship that we have with the patients and consumers. Yet without appropriate and dedicated reimbursement, pharmacies struggle to consistently allocate the time and the resource required to meet this expectation. Advancing this work will require continued engagement with DHCS and commercial payers. It has to become with the payers conversation that the existing statutes that we already have in California, such as SB 493 and AB 1114 and AB 317 lately. So to reliably meet the duty to consult, pharmacy needs, first, they need the appropriate reimbursement for consultation for the time. And then number two is bidirectional health information technology to document the care and the access to accurate patient information. Without having the accurate patient data, shared decision-making model cannot be achieved, and it increases much more administrative burden. Essence to these supports, consultation risk becoming a check the box operational task that may inadvertently increase the risk of consumer harm. CPHA also applauds the board movements towards the standard of care model through AB 1503, which we'll discuss further later today's meeting, which that standard of care spirit really provides the professional judgment and determination of when and how the consultation should occur and rather than relying on to prescriptive language to require them to do so. So CPHA looks forward to collaborate with the Board of Pharmacy and stakeholders to modernize the regulation, and consultation remains both clinically impactful and operationally feasible. Thank you so much.
Thank you.
And circling back to Paige Tally. Paige, I've sent a request to unmute your microphone. All right, Paige seems to be having some issues unmuting her microphone. President O, would you like me to open the chat for her to submit her comments?
I'll defer that to our chair, Serpa, but I think if she can connect later, we could just allow her to speak later.
Okay.
That sounds fine. I still have many items on my presentation, and if she does connect at some point, we could add that for
All right,
comments.
I will keep working on that with her. And with that, I will turn the floor back over to you, Chair Serpa.
Thank you. Members, you can see that this is a very dynamic and diverse topic. Even though it appears to be on only one issue, it actually is a continuum of issues. The committee will continue to discuss it and keep the board informed. With that in mind, members, do you have any additional comments before we go on to the next comment or the next agenda item?
I am, Member Serpa. I just want to say that I will be stepping out in 4 minutes and will be returning shortly.
Okay, the next item does have a
And-
vote, so you might not be able to vote on it.
And Maria, I
okay.
see Jessie and Claudia had her hands raised, so I'm not sure if
Okay,
they meant
thank
to or
you.
not, but
Let's go with Jesse. I can't see you guys, sorry.
Oh, that's okay. Thank you, Maria. I just wanted to follow up on a couple comments made. Just for the record, I don't agree with the idea of a technician screening for consultation. I've had several technicians throughout my career, countless times in which they have supposedly screened a patient for me, claiming that a medication was a refill when it wasn't, when I actually review the patient profile. And until there's more autonomy in the law that removes the responsibility from the pharmacist, if that were to happen, at this time, I don't think that's a good idea, unfortunately. I definitely agree with the concepts, as I said before, that there needs to be some less prescriptive requirements for consultation, in especially in certain settings, but especially in retail when we're talking about changes where it may be a doctor that's changed or the directions that have changed. But wanted to just note those two things for the record. Thank you, Maria.
Thank you, Jesse. And Claudia, was that you who had your hand up?
Yeah, I just want to say thank you for all the people that are there and who gave their public opinion. I think that's good information and things that we will consider as a board. So please keep showing up.
And just to add one more thing, Maria, sorry. I think a good example of a situation, as we all know, is the GLP-1s, right? So people are getting on 2.5 to start, like a Zepbound, but then like next month they're going to 5. And it's a great opportunity to do the consultation to confirm the dosage. But all the requirements in our regulation, it really is not a practical thing. It's great for pharmacists to provide that consultation, but just not in the sense of how it's written in our consultation reg, in a sense that just confirming the dose and making sure they know how to use it. It's a great opportunity to just double check the patients on top of it. But when you go up to 2.55, 7.5, 10, right, every dose increase would require technically our consultation, right? And that would technically require our consultation requirement to be fully compliant with our law. But I think in practical sense of standard of care approach, is that really necessary? That's the question. And I hope that we move forward with a better approach. Thank you.
Thank you. Any further comments before we move on to the next agenda item? Okay, so I think that means none. C, summary of discussion on hospital pharmacies and Business and Professions Code 4113.1, medication error reporting, include possible action to initiate rulemaking to amend California Code of Regulations, Title 16, 1710. Members, background information on this agenda item is provided in the meeting materials. As you may recall, the board refers to the medication error reporting under Business and Professions Code 4113.1 as the California Medication Error CAMER program. Subdivision C of section 4113.1 defines community pharmacy for the purposes of this section to include any pharmacy that dispenses medications to an outpatient. Existing regulation, California Code of Regulations, Title 16, 1710 establishes the conditions and sets volume limits under which a hospital pharmacy may furnish drugs to outpatients, employees, or walk-in customers. The committee agreed that the board has previously expressed its policy and intent that the camera reporting would not require hospital pharmacies to register. There are existing requirements that already apply to hospitals under the Health and Safety Code, including requirements to report adverse events and to adopt a formal plan to eliminate or substantially reduce medication-related errors. The board received comments during the previous committee and board meetings asking for clarity on whether hospital pharmacies are required to register and to report to CAMR. During the October committee meeting, the committee considered a possible change to the regulatory text in 1710 to provide further clarity to the board's regulated public that the term community pharmacy, as defined in 4113.1, does not include hospital pharmacies operating consistent with subdivision A of 1710. I'm sorry, there's a lot of references here, but that's important because it has caused a little bit of confusion. So during the meeting, the committee discussed this issue, and there's a general consensus that the language is representative of the board's policy in agreement to refer draft language to the full board. So because of the confusion, we are making this suggestion for this minor adjustment to the regulations to put in the regulation what our previous intent and discussions have been at previous meetings. In addition, the committee members expressed an interest in board staff learning more about hospitals dispensing prescriptions to outpatients to understand better what this represents. Attachment 3 includes a copy of the proposed regulation. As we begin member comments, should the board believe proposed language is appropriate, a possible motion to formally initiate rulemaking is included in the materials and displayed on the next slide. Oh my goodness, get your glasses out. Members, any comments? And I would appreciate a motion. I can't
Maria,
see.
this is Renee. I just wanted to say that it was a great discussion that we had there regarding this. And I do believe that this would be a good clarification to really avoid the confusion that exists currently for hospitals.
Thank you. Would you like to make a motion, Renee?
Yes. Anybody else have a comment before? No.
We'll still take comments after too.
Okay. And then is the text in that screen that's far, far away? Is it the same that's in our materials? Okay, so I shall be reading that then. Okay. So I'd like to make a motion to initiate a rulemaking to amend California Code of Regulations Title 16, Section 1710 as proposed, and authorize the executive officer to further refine the language consistent with the board's discussion, direct staff to submit the text to the director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any technical or non-substantive changes to the package, and set the matter for hearing if requested. If during the 40-day comment period, the board does not receive any comments providing objections or adverse recommendations specifically directed at the proposed action or to the procedures followed by the board in proposing or adopting the action, and no hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulation at section 1710.
I second that. This is
Thank you. Thank you both. With a motion and second on the floor, members, do you have any comments or questions before?
So sorry to interrupt. I just wanted to make sure that it's going to be a 45-day comment
45
period.
days. Yes, I'm sure that's what Renee
That's
meant.
part of the motion.
Renee, if you could just.
Yes, that's in the language. If during the 45-day comment period, they don't receive any comments.
Yes, thank you.
Okay, thank you.
Hey, members, I can't see everybody, so do you have any comments or questions on the proposed regulatory change?
I don't have
On
any
the
member
motion.
comments.
No member comments? Okay, let's begin with public comment for those in Garden Grove.
Nobody seems to be eager to come up here yet, so I'm gonna say that as a no, Chair Serpa.
Thank you. We're ready for public comment for individuals participating via WebEx.
All right, as a reminder, if you'd like to comment, please raise your hand. You can locate the hand icon at the bottom of your screen. If you're on a mobile device, locate that ellipses to access the hand raise feature. And for call-in users, you can dial *3. I will call on you by name, and when I let you know I've sent you a request to unmute your microphone, you will need to click on the Unmute Me button at your end to thereby unmute. Our first comment comes from Kathy Gomishi. I've sent you a request to unmute your microphone.
Hello, good morning. Thank you for the opportunity to comment. I am grateful to the board for revisiting this very important topic. I am a medication safety officer at an academic medical center that's part of a large system, and we've been working very hard to meet the intent of this regulation to promote a culture of safety, promote error reporting, learn from those lessons that we identify from the nature of error reporting, and make improvements to our health system practice. I will say that there's been a lot of gray area in determining which of our pharmacies and which of our patients this regulation is applicable to. And as we already participate in error reporting and sharing our data with a designated patient safety organization, we want to meet the intent and the letter of the regulation. So thank you for the opportunity to clear up some gray areas. This might include, but is not an all-inclusive list, but areas such as infusion centers, patients receiving medications at infusion centers, patients who are receiving medications from investigational drug services. So thank you for the opportunity to provide further comment to help clarify from the health system perspective, which of the pharmacies and patients this will be applicable to.
Thank you.
All right, and our next request comes from our calling user, number ending in 17. Sent a request to unmute your microphone. I see you are unmuted. We are not able to hear
Sorry.
you.
Yep.
Oh, there you go.
I had myself double muted. Sorry about that. This is John Gray, registered pharmacist of Kaiser Permanente. Just wanted to express our support for the proposed modification to the regulation. We think this will provide the clarity that our hospital pharmacists are looking for. Thank you very much for the opportunity to comment.
Thank you.
And that was our last request for comment. Turn the floor back over to you, Chair Serpa.
Thank you. Members, any final comments before we go to the vote?
No comments here.
Seeing none, I turn the meeting over to you, President O, for the vote.
Thank you, Chair Serpa. Jesse, how do you vote?
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole. Nicole? Nicole is frozen on my screen. Okay, I think we'll just have her be no voting, but
There she is. Nicole, you keep going.
Sorry,
Unmute.
sorry.
There-
I don't know if you heard me. I said yes. There was some
okay.
internet connectivity issues, but it's
Thank you,
back now.
Nicole. Thank you, and I vote yes. Back to you, Chair Serpa.
Thank you. Moving on to D, summary of discussion on frequently asked questions related to Assembly Bill 1286, including possible action to approve proposed updates to FAQs. The background information on this agenda item is provided in the meeting materials. Attachment 4 includes a copy of the updated FAQs. You will note that the committee is offering a recommendation to approve the proposed updates to the FAQs, including additional updates made after the committee's discussion to reflect changes on the board's Sunset Bill AB 1503. With the committee's recommendation serving as the motion, members, do you have any questions or comments on the updated FAQs?
I don't see any member comments here.
I know we've reviewed these FAQs. I do appreciate staff and the committee's constant updates because this is an area that people are asking a lot of questions about. Seeing no member comments, is there public discussion in Garden Grove?
Don't see anybody coming up to the microphone, so nope.
Okay. Moderator, we're ready for public comment for people participating via WebEx.
All right, we are looking for anybody who would like to comment on this item on WebEx. Again, you'll need to raise your hand so that we can see your request. Locate that hand icon or dial *3 if you are on a phone. And seeing none, I'll return the floor to, oh, stand by. We have one request from Kathy Gomishi. Kathy, sending you the request to unmute.
Hello, thank you for the opportunity to speak on this topic. I would be appreciative of the board being able to revise the frequently asked questions section for Assembly Bill 1286 to help promote better clarity, particularly for the CAMR med error reporting program. And if this also pertains to the previous topic, just any feedback that is received to help sites have a clear understanding of how best to be compliant with these regulations. Thank you.
Thank you, Dr. Gomeshi. I think there are 2 questions in there, but we certainly at the next committee meeting can look at the one that talks about infusion centers, which I think was your area. It may be able to be edited for the next version. Any other public comment?
That's the only one, so I will return the floor back to you.
Thank you. Members, any further discussion before we go on to the vote?
Don't see any.
Okay, President O, I've turned the meeting over to you for the vote.
Thank you, Chair Serpa. Jesse, how do you vote?
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, Jeff is not here. KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Just for planning purposes, we're gonna probably take a break at like 10:30-ish. So if that works. So we'll turn it back to you, Chair Serpa.
Thank you. Before moving on to E, I just wanted to ask Shelley if she got a hold of Paige Talley. There's an opportunity to speak here or after E.
I'm gonna cue her up again and see if she can unmute. Paige, I've sent the request to unmute.
Okay. Sorry for there's a little bit of unfortunate circumstances. Thank you. We're now down to 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6. Okay. So we're probably gonna have to take a break. We're gonna have to take a break, Chair Serpa. We're gonna take 15-minute break and we'll come back at 10:30. I'm so
Okay.
sorry.
That's not a problem. I don't think there are any more votes in my report, just for your information. Okay.
Okay. All right. We'll take a break. We'll come back at 10:30, everyone. call. Jesse, are you? Thank you, Cisco. Jesse, are you back? I don't see her on my screen, but she might not be back. I'll move to Trevor.
Present.
Thank you, Renee.
Present.
Thank you, Jeanette.
Present.
Thank you, KK.
Present.
Thank you, Claudia.
Present.
Thank you, Jay.
Present.
Thank you, Ricardo.
Present.
Thank you, Satinder.
Present.
Thank you, Maria.
Present.
Thank you, Nicole.
Present.
Thank you, Jesse. We do thankfully
Okay.
up there.
Hello, I'm here. Sorry about that.
That's okay, Jesse. Thank you. And I'm here. All right, Chair Serpa, back to you.
Thank you. Before moving on to agenda item E, I just wanted to circle back regarding the public comment on A from Paige Talley. Has she been? I'm going to try her again. I did have to log out and back in because I was having some technical issues at my end. So I want to make sure it wasn't as a result of that. Paige, I have sent you a request to unmute your microphone. You should see an unmute me button at your end. I've also sent Paige a chat to let her know that if she's having issues, we can find an alternative. And I'm not seeing any response out of her microphone, so I'll just keep an eye on the chat to see if she responds back to me that way. Great, thank you. You're welcome. Moving on to agenda item E, summary and discussion of recently signed legislation impacting the practice of pharmacy, including possible discussion and action on proposed implementation activities. Members, as we do at our fall meeting each year, the committee discussed enrolled legislation that was either signed or vetoed by the governor. Note, measures that were vetoed by the governor are not included in this report. The first measure for our discussion is Assembly Bill 82 regarding legally protected healthcare activity, which expands the address confidentiality program to a gender-affirming healthcare provider, employee, or volunteer who faces threats of violence or harassment from the public because of their affiliation with a gender-affirming healthcare service facility. The bill also prohibits a prescription for or the dispensing of testosterone or mifepristone from being reported to the Department of Justice, Cures, or a contractor as specified. The committee noted agreement with the implementation activities offered by staff. Members, do you have any comments on AB 82?
We have one.
I'd just like to state how proud I am that the Board of Pharmacy stood with this legislation and supported it. And during these particular, just want to say how proud I am to be a part of a board that supported this legislation in these very tense times to protect gender affirming care as well as reproductive health access.
Thank you. Any other members?
This is Nicole. I'll add on to what Trevor said and say it's so important that we're doing this. Just last week, the federal administration came out and released plans that they are going to, one, not pay for any gender affirming care for youth in Medicaid, but potentially also not make any payments to anyone that provides gender affirming care to youth through Medicaid. So you'll essentially be cut off from Medicaid and Medicare if you provide these services, which is not consistent with California law, this adding to that. So it's going to have to be a legal battle here in California, but I'm glad to see that we are standing with the trans community.
Thank you. Any other member comment before we go to public comment? Okay, any public comment in Garden Grove?
I don't think so, Chair Serpa.
Okay, moderator, we're ready for public comment for individuals participating via WebEx. All right, if you'd like to make a comment, please raise your hand. You can find that hand icon button at the bottom of your WebEx screen. For mobile users, you can find the ellipses or 3 dots to access the icon. And for our call-in users, you can dial *3.
And not seeing any requests. Here we go. Sean Kim, you are up, and I've sent you the request to unmute your microphone.
Thank you, Board. CPHA also supports the Board's implementation for AB 260 to ensure sustainable access to the medication, abortion, and gender-affirming care. We've been collaborating with the birth control pharmacist, and we also seek for help with the CDPH for continuing of the care for Californians. So thank you so much, and we applaud your efforts on AB 260.
Thank you. I think that's going to be coming up soon, but they're very similar, or there are some similarities in the bills.
And seeing no other requests for comment, I'll return the floor to you, Chair Serpa.
Thank you. Our next measure for discussion is AB 144, which authorizes pharmacists to independently initiate and administer immunizations that, as of January 1st, 2025, had a federal ACIP recommendation or are recommended by the California Department of Public Health. The committee noted agreement with the implementation activities offered by staff. Members, do you have any comments on AB 144?
Don't believe so here. Jesse's hand is raised, Maria.
Thank you, Jesse.
Thank you. I just wanted to note for this measure too, how important it was. And I just appreciate that California was so on top of this. I don't know if anyone else had a chance to watch some of those ACIP meetings, but it was quite a nightmare. And so I'm just very grateful that our consumers in California are going to have access to immunizations if they choose to access them. Thank you.
Thank you.
This is Renee. I also wanted to comment just to say that I also, in terms of consumer protection, this is a really important step to provide the public with consistent messaging about the vaccines based on actual science and for their health and welfare. So it's just really great legislation.
Any other comment? I would like to add my thanks to board leadership and staff for notifying licensees of their additional opportunities to continue to provide vaccines, because it was confusing if their only resource was the media. And so I appreciate the board getting out the information to licensees about what was legally authorized. Any other board members? Okay, public comment in Garden Grove.
We don't have any.
Thank you. Moderator, we're ready for public comment via WebEx.
All right, again, raise your hand if you'd like to make a comment on this item. We are displaying instructions for your use. For call-in users, you can dial *3. Our first comment comes from Sean Kim. And before I unmute his button, I did receive an email from Paige with her comment whenever you are ready to receive that. So Sean, I'm sending you a request to unmute your microphone.
Thank you again. I apologize. I was ahead of myself and comment about AB 260 confused myself. But this is for AB 144. So we appreciate the board's communication on AB 144, which authorized pharmacists to independently initiate and administer under ACIP recommendation, which was approved before January 2025, and CDPHA recommendation for individuals 3 years of age or older, effective in September 17, 2025. So this really helps the gap of the care for the California pharmacists to provide immunization, both federally and state immunization recommendation. CPHA respectfully notes, however, that the board's recent alert on the webpage updated information on pharmacists' authority to administer vaccines, specifically for the statement that business BMP code section 4052A11 currently provides the pharmacist with authority to administer immunization to any person regardless of age and pursuant to protocol with a prescriber. So this statement has created some confusion amongst some licensees. The statement may be interpreted as suggesting that pharmacists have independent immunization authority does not take effective until January 1st, 2026 under AB 1503. Even though that it was addressed that AB 144 provides the independent authority to the patients 3 years and older beginning of September 17, which is addressed on the bottom of the page. But then, since that 1503 statement was on the top of this web page, so it could also potentially create some confusion. So to avoid this misinterpretations, CPHA recommends the boards to clarify the update outlining the relationship between the overlapping authorities of AB 144, which is effective since September 17, 2025, and AB 1503, which is effective in January 1st, 2026, that allows pharmacists to immunization authority under the standard of care model. And CPHA supports the board's education outreach efforts and stand ready to collaborate on clear implementation of materials to ensure consumer safety. Thank you so much for letting me comment.
Thank you, Dr. Kim. I appreciate your comments. I'm sure board staff have heard your comments and will look at future alerts that are sent out to with that in mind. Any other?
That is our last comment for this item.
Thank you. And then Shelley, also for Paige, will take her comments on item A after we finish this agenda item.
Sounds good.
Okay. Okay, next measure for discussion is AB 260, which authorizes pharmacists to dispense medication abortion drugs such as mifepristone without including patient name, the prescriber's name, or pharmacy identifying information on the label. It also provides legal protections for pharmacists, protecting them from criminal or civil liability and professional discipline when dispensing these medications in compliance with California law. Members note the importance of legislation to maintain access to reproductive health care and agreed with staff recommended implementation activities. Members, do you have any comments on AB 260? Jessie.
Hi, thank you, Maria. My one comment, and it says that no public comment had been received, but I'm curious if anyone is familiar with the software systems and whether or not they would actually allow excluding a patient's name on label. That was the only thing that I noted, just personally, but I have full support of this. I think it's a great piece of legislation and just another testament to the good work that California is doing right now for its consumers.
Thank you. Any other member comments?
Nicole has her hand raised, Chair Serpa.
Thank you, Nicole. I couldn't see you.
Hi, Jesse. I was just going to respond to you to say that there's often workarounds. It's kind of like what you do when you're doing like a sexual health STI treatment for a partner where you don't necessarily have their name. So you can create the label through like almost like a dummy profile. But this is where it gets tricky, that the drug may not necessarily appear on that person's profile later. So there are workarounds, but what the record looks like after the fact can be a little tricky. I'd also flag, speaking to the piece about software, is that some software links to other states. Obviously, we know that with big chain pharmacies, but also things like Epic, which is very commonly used, is a shared profile. So if your patient goes out of state, it may be able to be seen somewhere else if this is in that profile. So that's why this is so important.
Thank you. Any other comments from members?
Claudia also has her hand raised. Chair Serpa.
Thank you, Claudia.
Thank you. I wanted to follow up with Nicole. So from what you just mentioned, just to clarify, will the physicians in the next, let's say, patient visit, will they be able to tell if they took this medication?
It depends on how they end up using this law. And that's part of why it exists. So if you do it without labeling, they may not be able to see, depending on your software and how you label it. And part of the concern for that is that if it did show up and the patient went to another state where this wasn't allowed, abortion, things like that, that other state might be able to see it and try to take action on your patient, if that makes sense.
Yeah, so in terms of physicians providing standard of care and potentially noticing side effects or things that might have gone wrong with the particular patient after they took this medication, we wouldn't be able to, I guess there's going to be somebody's going to be blindsided because all the data is not being shared, which is a good thing, but it's also potentially can harm the public because there's no data on what they consumed. That's what I'm hearing.
I think the idea, part of it being that the patient could provide the information. And again, this isn't the first time that the first situation in which this exists. So we've seen it before in other cases. It'll be a rare scenario, and it's a risk versus benefit, balance.
Right. Okay. Well, thank you for that, Nicole. I appreciate it.
Jessie also has her hand raised. Maria?
Thank you so much, Nicole. That's very helpful. So then I don't know if this is directly to Nicole. I won't direct it to you, but I guess the other piece that I have a question about is the prescriber's name not being on the label. I know particularly with my software or the ones that I've used in the past, you usually can't enter a prescriber without having at least some piece of information, whether it's a license number or an NPI or DEA or something like that. And so I'm curious if we've had anything like this in the past, and if we think this may be a barrier for pharmacies to be able to implement.
Those are all good questions. Operationally, I think every organization may have a different answer. That's very common with laws, is it doesn't tell you how to operationalize it. But those are all good questions. Any other member comment? Okay, we're ready for public comment in Garden Grove.
No public comment, Chair Serpa.
Okay, moderator, we're ready for public comment via WebEx. Okay, for our attendees on WebEx, if you'd like to comment, please locate that hand icon. Raise your hand. Our first comment's going to be coming from John Gray. John, I've sent you the request to unmute your microphone.
Hello, good morning. This is John Gray, registered pharmacist with Kaiser Permanente. Just want to respond directly to Board Member Crowley's question about organizations and their pharmacy information systems ability to omit certain information from the prescription label, like patient name, prescriber name, etc. Our preliminary analysis of Kaiser Permanente is that our system cannot currently support that function of omitting information from a prescription label. Kind of the level of effort and level of expense that would be required to modify our information system to do that is something that we're currently exploring. But I anticipate it would be a slow and expensive process if we decide to move forward with those changes. Thanks for the opportunity to comment.
Thank you. And not seeing any other requests for comment, I return the floor to you. Thank you. Members, any additional comments before we move on?
Maria, sorry, this is Corinne. I just wanted to chime in just for members' clarification to make sure that people know that the way the law is written, it's not a mandate. It's a pharmacist may at their discretion.
Thank you. I don't think that was quite understood. Members, any further comments before we move on? Okay, the next measure for discussion is AB 309, makes permanent the allowance for pharmacists to furnish hypodermic needles and syringes to persons over 18 without a prescription or permit. Additionally, the measure makes permanent the requirement for pharmacies that furnish non-prescriptive hypodermic needles or syringes to provide written or verbal counseling to consumers at the time of furnishing or selling. Members noted agreement with the implementation activities recommended by staff. Committee members did. Members, do you have any comments or questions about the implementation activities for AB 309?
Chair Serpa, I just have one comment about this bill, which is great. I'm happy that this is the sunset is struck out of the bill, but I also would like to just add, since we're talking about AB 1503 later and that it's not agendized, friendly reminder that it's changed to now allow pharmacists to initiate and furnish all basically test strips, lancets, any medical devices. So I think that that would allow pharmacists to be able to use their authority to dispense such devices as hypodermic needles and syringes via their own prescribing authority.
Thank you for that additional information. Any other member comments? I can't see everybody, so any comment in Garden Grove from public?
Seeing none?
Thank you. We're ready for public comment via WebEx. Moderator?
Anyone would like on WebEx would like to comment on this bill, please raise your hand. For calling users, you can dial *3. Our first comment comes from Chasney Johnson. Chasney, I've sent the request to unmute.
Hello, my name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. I would just like to make a comment about the needles being purchased, even if it's at 18 years or older. There's a lot of retail stores that are surrounded by schools. We know like teenagers can look older than what they are. So it would be cool to just, I don't know, like even working at Target, sometimes it would be nice to like have a picture ID, just so it even says age 21 by certain age. So you can kind of calculate how old they are, or if it was a function on the cash register where you can type in their first and last name, just to have like a security function. So it's not like somebody's just walking in here buying needles for fun. We want to make sure it still is like a safety measure, but that would be my comment for this agenda item. Thank you.
Thank you.
And seeing no other requests, I'll return the floor to you.
Thank you. Members, any other further comments on this item? Okay, moving on. The next
Hi, Maria. Sorry, it's Nicole. If I could make a comment.
Sure.
I just kind of expanding on the commenter that was just speaking. I know when I worked in retail, there was a lot of hesitation on providing needles to people. For some reason, people really wanted to make sure. And, you know, I just want to remind everyone that the reason that we provide clean needles is because it's a harm reduction measure. There's almost never harm in giving someone clean needles. You know, if someone needs needles, you want them to have clean needles. So, you know, as much, we definitely want to be safe and we definitely want to follow the law, but you are almost never, I can't think of any scenario when you're harming someone by providing clean needles. So just putting that out there.
Thank you, Nicole. Any other comments?
Hi, Maria. This is Jessie. I will say I have worked at pharmacies in which we've dispensed needles to patients without prescriptions, and they use in the parking lot and then leave needles out. And so in that sense, it is a harm to the community if they're not disposing of it properly. Unfortunately, a lot of the safety containers can be expensive. Sometimes it's like $30, unfortunately. And realistically, people may not be able to afford that. So moving forward in the future, I would love to see a way in which we could be able to give people clean needles, but also give people affordable or free options for safety containers as well, so that we kind of address both concerns.
Thank you. Any other comments?
This is Claudia. I wanted to follow up with what Nicole was saying. So as of now, if somebody wants to buy needles and there's no prescription, the pharmacist doesn't have to log in their information. So it's just like literally a retail sale, goods for services and goods for cash, and that's it.
This has been the law for a while. This is just making it permanent so it doesn't sunset. We can sell without clean hypodermic needles without a prescription.
Right, but so there'll be no record of that person buying. I just want to clarify that for myself.
Right.
Correct. Okay, thank you so much.
Thank you. Any further comment?
Oh, we actually have an in-person comment, I think. Yep. Okay. Thank you, Dr. Dang. Thanks for breaking the chain. Yay.
Hi, Richard Dang speaking on behalf of myself. I think it was Jesse's comment earlier. There are some local resources from counties, cities, and the state that offer free sharps containers to individuals that can be requested. So that can be a great resource that pharmacies and pharmacists can provide to their patients when they're providing these hypodermic needles. Thank you.
Thank you. I'm glad you mentioned that, Dr. Dang, because I know in my county, Sacramento County, free sharps containers are available on request. Not from pharmacies, but from waste management. So since we had additional public comment, I think we need to ask members again if they have any comments. Okay, seeing none. I'm sorry, Dr. O, what did you say?
Oh, sorry. I was just letting you know we do not.
Okay, thank you. Our next measure for discussion is AB 447, which allows prescribers to dispense the unused portion of a dangerous drug as defined, excluding controlled substances that the hospital acquired to an emergency room patient upon discharge, provided it is necessary to continue treatment. As noted in the meeting materials, there are details regarding the medication limitation and labeling requirements. This measure also exempts certain automated unit dose systems from licensure requirements when used to dispense drugs to emergency room patients. This committee agreed with the implementation activities recommended by staff. Members, do you have any comments on AB 447?
Hi, Maria. This is Renee. I do, and I'm asking as somebody who's only ever worked in a hospital setting, and I don't do much with outpatient prescriptions. So, but when I see this and the labeling of these, is this considered then an outpatient prescription? It simply is labeling, and it's the hospital order that it counts towards.
So currently, many hospitals do have a way to label medications for patients to take home, either as a discharge or a relabel, like for an inhaler. So it is, maybe staff can respond to it, but in my experience, it does have a separate prescription number, so it's an outpatient. But
sorry, so
maybe staff
is an outpatient or not?
So maybe staff can clarify that, but in my experience in the hospitals I've worked at, it's always been a separate prescription number and labeling.
I'm just wondering, in this case, then would these count in a hospital setting for outpatient prescriptions that would be tallied for our previous discussion for CAMR, like the 1%, the less than 1% outpatient prescriptions to count whether they're excluded or included? I don't know if I'm wording that correctly. Does that make sense? Just wondering if this bump people up over the, whether they have to report, because if they just, these drugs that go home with the patient, are they outpatient prescriptions considered?
So staff, do you have any comments or on that? I can tell you what my experience is, but that's just my experience. So in my experience, it's the hospitals that I've worked at has always had a relabel program. So I don't see that in those facilities that there would be an increased number of prescriptions because they currently do that. There may be facilities that don't, and so that may change for them.
This is Corinne. I mean, I will just chime in to your question about the hospital pharmacy regulation, just to say, the way that it's worded and the way that I read it is that the 1% applies to walk-in customers.
Oh, okay. Thank you.
Well, okay.
I guess if they walked into the emergency room. Anyway, okay, this probably does not. I just kind of wanted to ask that question.
Uh,
Go ahead, Kate.
This may have been discussed, but what will be the pharmacist's requirement for counseling or consulting when patient is discharged to home from
So
the emergency room?
So this was what we talked about when the bill was being discussed. So this is from the emergency room and bypasses the pharmacy and the pharmacist.
Right. Yep.
Yes.
Yeah.
Yeah.
So I
We
think this
asked
is
for, at that time, we did ask for amendments and they were not accepted.
pertaining to a prescriber dispensing
Right.
of unused portion. So that's probably something to keep in mind.
So it is really, again, it is an unused portion of a single dose or of a multi-dose single patient thing. So it's like eye drops, inhalers, topical ointments. So there are limitations on the types of drugs and there are specific requirements for labeling. Any other comments from members? I know this is going to be confusing to the public, but Claudia.
I just wanted to ask the staff in terms of the implementation. This is going to be, our communication to the licensees is going to be done. I see here in the notes through the script. We're going to be updating other sorts of information. Any additional things that we might be able to do to provide more clarity?
So I think that sometimes we have to kind of see how it's being operationalized in the field to maybe gain some additional understanding of where there might be additional items. If we determine that like FAQs might be appropriate or those kinds of things, we'll definitely bring it back to the chair of the committee with a recommendation to maybe consider some things. But I think at this point, because it hasn't necessarily been implemented yet, I think we're, kind of going with some of the basic things. And then as we understand where there may be gaps in information, looking to see if the law provides additional clarity that we can leverage for FAQs. Hopefully that kind of makes sense.
Yeah, that sounds great. Thank you.
Any further
Yeah, I
comments?
just wanted to,
Oh, go ahead.
sorry. I just wanted to chime in from what I understood from explanation the council gave and reading of it is that seems like an intent is to not delay a treatment so the patient is receiving these doses that you would be wasted otherwise if the pharmacy is now open at the time to relabel it for them to take it home. This way they can go home and the prescription could be provided to them to be taken home. I think its scenario is more for like, I don't know how often that happens in pharmacy. In emergency rooms, I'm not, I don't work in that setting. So I think I agree with and that, we would see how, if it is an issue with this and then provide, as it's necessary, more clarification.
Claudia?
Yeah, and also seems that this could be a good way for people to have access to their medication right after they get discharged. Because I know from my experience with my family, it could be hard for certain individuals to get to the pharmacy and pick up their prescriptions. So we'll love to keep an eye on this and work with the staff to make sure we implement it correctly.
Any other comments? Okay, we're ready for public comment in Garden Grove.
Not at this point.
Okay, moderator, we're ready for public comment for people participating via WebEx. All right, if you'd like to make a comment, please find that hand raise icon on your screen or device. Either the button at the bottom of your WebEx screen, the ellipses on your mobile device, or *3 for calling users. And our first comment comes from Tim Lopez.
Tim, I've sent a request to unmute.
Yep, thank you. My name is Tim Lopez, a registered pharmacist that works with community medical centers here in Fresno, California. Yeah, so the concern with this is our inpatient pharmacy, like many other inpatient pharmacies, do not have the facilities to meet the labeling requirements that are described in section 4076. So that would be a rate limiting step for us. In addition, I agree with one of the members' earlier comments that I think it'd have to be clarified whether or not this counts towards an outpatient prescription and that 1% rule that's described in section 1710, because the way I read it is that it would be. So I would like clarification for that as well too. Thank you very much.
Thank you. Not seeing any further requests, I'll return the floor to you.
Thank you. And I guess just to provide clarity, there are hospitals that are already doing this, but via a pharmacy program where the pharmacy pre-labels and has log books and all sorts of documentation that the medications go pre-labeled correctly to the patient. Those facilities that don't have the pharmacy involved, this law now allows it to bypass the pharmacy. So the prescriber, the physician, or prescriber would be still required to label those medications just like they do currently when they dispense from their offices. And we know that that's not often done correctly either. So members, any other comments before we move on? We knew this was a problem-prone one. Yeah, something that I've talked about since the very beginning.
This is Renee. I think there, just throwing, because I think there are a lot of nuances here, and it may be that my experience is in pediatrics. And so the usage of some of these unit dose in the emergency room is different than for when they go home. So, that again, that would be just part of this discussion.
So unit dose is not applicable. They don't go home with you. It has to be a multi-dose, single patient use product. Any other comments from members? I'm sure we're going to talk about this again as questions come up once it's implemented.
Yeah, I have a comment about record keeping, especially what has been given to patient and where would be the repository of that? And would that be under purview of, let's say, board inspector when they go and inspect?
That was one of the concerns the board brought up when this was being discussed, because it bypasses the pharmacy as in their inventory, and it also bypasses the pharmacy for documentation. So there are no pharmacy records, but I'm sure that the emergency room record would have something. They do document what care happens in the emergency room. It just would not be part of the pharmacy record. We tried to bring up those issues with the amendments, and those amendments were not accepted.
Thank you.
Okay, moving on to Senate Bill 40 related to healthcare coverage and cost restrictions for insulin. Members agreed with staff recommended implementation activities. Additionally, members highlighted the committee meeting that federally qualified health centers that purchase insulin at 340B prices, there are separate requirements based on a White House executive order. Members, do you have any comments on SB 40? Nicole, I know you're the one that mentioned the executive order. Did you want to comment on that?
No, you covered it. My whole point with that is just for people who are at FQHCs to know you have to follow both. This does not replace the other one. It is two separate things.
Thank you. Members, any other comments? Seeing none, we're ready for public comment in Garden Grove.
None at this time, Chair Serpa.
Thank you, moderator. We're ready for public comment via WebEx.
If you'd like to comment on this bill, please raise your hand. Clicking the hand raise icon at the bottom of your screen, accessing that hand raise option through the ellipses for mobile users, And for call-in users dialing *3. I'm not seeing any requests come in, so I will return the floor to you.
Thank you. Moving on to SB 41 relating to pharmacy.
Sorry, Maria, this is Jessie. I just raised my hand late, but just thought of something of note. My understanding of this, and correct me if I'm wrong, is that this applies to insurance companies. And so it may be a good idea for us to have some outreach to pharmacies about this. I'm not sure how it applies to, say, a discount card, but if you do have patients who don't have insurance and are used to using something, some sort of discount card, it may be good to make sure that pharmacists understand this sort of program. I mean, it sounds like it only applies to insurance, so I don't know if that comment is necessarily relevant, but just wanted to throw that out there.
Thank you. I think the materials say that we were looking at providing information to licensees and the public.
Perfect. Thank you, Maria.
Thank you. Any other comments before we move on? SB 41 relates to pharmacy benefits managers and prohibits them from requiring patients to use only affiliated pharmacies or are from discriminating against non-affiliated pharmacies in dispensing drugs. Beginning in January 1st, 2027, PBMs must be licensed by the Department of Managed Care. Members noted agreement with the staff recommendation implementation activities. In response to a recommendation by the committee, staff has contacted counterparts at DMHC for coordination purposes. Members, do you have any comments on SB 41? I don't think there's any comments in Garden Grove.
None at this time, Chair Serpa.
Moderator, we're ready for public comment via WebEx.
Right. We're opening up public comment on this bill. If you'd like to make a comment, please access that hand raise icon. Our first comment comes from Sean Kim. Sean, I'm sending you the request to unmute your microphone.
Good morning, board. Sean Kim from CPHA. CPHA strongly supports the implementation of SB 41 as the bill's sponsor. SB 41 is a monumental step towards transparency, fairness, and accountability with pharmacy benefit managers. We applaud the collective multi-year advocacy across all practice settings and interprofessional partners and the board supports that advanced transparency across the healthcare system. SB 41 complements with the budget bill AB 116, which was signed June 30th, which requires PBM licensing through DMHC, Department of Managed Healthcare. Together, these measures directly address long-standing barriers to patient access and health system viability across settings, not only community-based pharmacies. CPHA agrees with the board's plans to emphasize education through the annual changes in pharmacy law webinar, the script, and the consumer-facing outreach. We also encourage close collaboration with DMHC to ensure the coordinated framework for complaints intake, investigation, and enforcement, particularly during the PBM licensure transition prior to January 1st, 2027. Effective oversight will also require active communication with HCI, Healthcare Affordability and Information's Healthcare Payment Data, HPD program, which will collect and analyze PBM-related data such as drug codes and names, prescriptions and patient counts, discounts, rebates, information needed to access payments to PBM-owned pharmacies. So this is a lot of information that has to be sorted through with interdepartment of efforts. So according to the HPD's PBM data collection roadmap, PBM registration begins in 2027 and historical ongoing data collection starts in 2028. Important across agencies and professions, wide discussion will be needed to align timelines and data elements and use cases. CPHA encourages board members and the public to participate in HCI and DMHC public meetings and stakeholder meetings to support proper implementations. It is critical that pharmacy professionals in the field are essential to ensure the right data to collect and analyze and effectively address PBM misconduct, and which ultimately harms consumers and patients, contributes to the healthcare desert. Thank you so much for letting me comment today.
Thank you.
And seeing no additional requests for comment, I'll return the floor to you.
Thank you. Members, any further comment on this measure? Okay, moving on. The next measure is SB 306 pertaining to prior authorization for healthcare coverage. This bill requires healthcare service plans and insurers to temporarily exempt certain services from requiring prior authorization if 90% or more of the requests for those services were approved in the previous calendar year. Members noted agreement with staff recommended implementation activities. Members, any comments on SB 306? I can't see. I think there's no comments. Is there any comment in Garden Grove?
None at this time, Chair Serpa.
Thank you. Moderator, we're ready for public comment via WebEx.
All right. For comments via WebEx regarding this bill, you can raise your hand using that hand raise icon. And Chair Serpa, if you'd like, while we wait to see if anybody wants to comment, Claudia Mercado does have her hand raised.
Okay, we'll come back. Let's finish with public comment.
All right. I have no requests, so I'll return the floor to you.
Thank you. Claudia, sorry, did I miss you?
It's okay. I was going to ask staff, it did say that part of the implementation, they recommend consumer-facing education activities. Can you guys briefly speak on that?
So I think as the provisions, so let me first say that like the provisions don't take effect immediately, right? So as the work starts to go, we do think that there's an opportunity to at least include some information on our website that lets consumers know where prior authorizations are not going to be allowed any longer, just as a way to try to help, consumers understand maybe some places where, knowledge is power, and helping them understand where they can maybe, advocate a little bit better to get access to the medications. I think the underlying, policy is to try to remove these barriers to care. And so as it gets implemented, we think that there's probably an opportunity to let consumers know.
Thank you.
Thank you. Any other member comment before we move on? Okay, the next measure is SB 470, which authorizes state bodies and advisory boards to conduct public meetings via teleconference through January 1st, 2030. Members agreed with staff recommended implementation activities. Subsequent to the committee meeting, staff suggested that the board might consider updating the board member procedure manual regarding the frequency of meetings policy from an interim to a permanent policy through January 1st, 2030. The proposed update to the procedure manual can be found in the meeting materials under attachment 5. As I open up for member comments on SB 470, I would entertain a motion that it be included, the motion that is included in the meeting materials and displayed on the screen, should be coming up on the screen, if you believe such an action is appropriate. Members?
I'm more than happy to make a motion, Chair Serpa, to approve the proposed update to the board member procedural manual frequency of meetings policy from an interim to permanent policy through January 1st, 2030. Or can I make it more flexible and say if the bill is extended again, that we could just go along with that? Corinne?
Excuse me, are you saying you want to?
Through January 1st or further?
Yeah, you can do that.
Okay. Or if the bill is also extended at that time, that we would automatically be allowed to continue the policy. Thank you, Ricardo. I won't be around 2030, but just for the future.
Okay, so we have a motion and a second. And just to be clear, the motion is through January 1st, 2030, or such future dates as authorized by legislation or something like that. Corinne, is that
Yes.
okay to say it that way?
That works.
Okay, thank you. Any other member comment? Okay, any public comment in Garden Grove? Okay, none. Any public comment? Moderator, we're ready for public comment via WebEx. All right, if you'd like to comment on this motion via WebEx for our WebEx users, please raise your hand using that hand raise icon at the bottom of your screen. For our mobile users, you can locate the ellipses to find that prompt. And for our calling users, you can dial *3.
Just confirming there was no public comment in person.
Thank you.
Go ahead, Shelley.
That's fine. And not seeing any requests for comment on WebEx either, so I return the floor to you.
Thank you. President O, I turn the meeting over to you for the vote.
Thank you. Was there any other comment? No? Okay, all right. Jesse, how do you vote?
Yes.
Thank you. Trevor?
Yes.
Thank you, Renee?
Yes.
Thank you, Jeanette?
Yes.
Thank you, KK?
Yes.
Thank you, Claudia?
Yes.
Thank you, Jay?
Yes.
Thank you, Ricardo?
Yes.
Thank you, Satinder?
Yes.
Thank you, Maria?
Yes.
Thank you, Nicole?
Yes.
Thank you, and I vote yes. Back to you, Chair Serba.
Thank you. The next measure for discussion is SB 497, which prohibits healthcare providers, insurers, contractors, and employers from disclosing medical information in response to civil or criminal actions based on laws from other states that penalize such care. It also bars cooperation with out of state or, where permitted, federal law enforcement agencies attempting to identify individuals involved in legally protected healthcare activities. Members noted agreement with staff recommended implementation activities and suggest that some education or guidance on this topic may be appropriate. Members, any comments on SB 497? Sure, someone's gonna say something. I can't see you.
We don't.
Okay. I know during the public comment, there was comment that there is some confusion amongst licensees, and that's why the committee is suggesting additional educational guidance. Any public comment in Garden Grove?
We do not.
Moderator, we're ready for public comment via WebEx.
All right, to comment on this bill, please raise your hand using that hand raise icon. As a reminder, our commenters have a 3-minute limit, and we do provide 10-second reminders. And seeing no requests for comment, I'll return the floor to you.
Thank you. Moving on to the next measure, SB 568 expands the authority of pharmacies to provide a broader range of epinephrine delivery devices, including those other than auto injections, to local educational agencies, including school districts, county offices of education, and charter schools, under existing safety and training requirements. Members agreed with staff recommended implementation activities. Members, any comments on SB 568?
None in the room here.
I
I see Jesse has on the hand.
Jesse, yeah. I just wanted to comment my appreciation for the expansion as someone who has food allergies and recently had an allergy. Honestly, it would be a lot easier, and I think we can save so many lives by making epinephrine as widely available for people as possible. So that's all, and I agree with the staff's recommendation as well.
Thank you.
Well, also just to chime in here, with our AB 1503, pharmacists can initiate and furnish EpiPens and all kinds of stuff. So just want to point that out.
That's true. Thank you. Any other comments from members? Okay, how about public comment in Garden Grove?
We do not.
Okay, moderator, we're ready for public comment for those participating via WebEx.
All right, for our attendees on WebEx, you can raise your hand or request a comment, clicking on that hand raise icon at the bottom of your screen, locating the hand raise prompt under the ellipses for mobile users, and dialing *3 for call-in users. Seeing no requests, I will return the floor to you.
Thank you. Members, any comments on this topic before we move on to the next topic, enforcement statistics? We'll take this opportunity to also circle back with Paige Talley. She had public comment on item A, duty to consult, I believe. And we were not able to hear her, but is she there now?
I do have an email from her with her comment. She's been having some issues with her microphone unmuting. She says that she uses a popular drugstore that is on every corner. And when she picked up a drug for her son, she was consulted. And when she told the pharmacist what the drug was going to be used for, he adamantly said no. It will not treat a facial fungal infection, especially if there are open wounds and they are bleeding. She was so very appreciative of the consultation, although had she not told the pharmacist what the medication was to be used for, the result could have been disastrous.
Thank you. Members, I think maybe Corinne, is it appropriate to ask members to comment on item A again, since we added additional public comment? What's the correct structure?
I mean, if you would like to, but then I think you'd have to open it up again for
Okay.
public comment.
Members,
we're
are you
good to
okay with
move
us
on.
moving on to the next agenda item?
Yes, Chair Serpa.
Thank you. Item, I don't have a letter on here. The last one, summary of discussion of enforcement statistics. The meeting materials include a summary of enforcement statistics for the first 3 months of fiscal year 25-26. The board has initiated 914 complaints and closed 747 investigations. As of September 30th, 2025, the board has 1,736 field investigations pending. The materials provide a breakdown of the average time frame for the various stages of the investigation process. And attachment 6 includes the statistics for the first quarter of the fiscal year. Members, do you have any comments or questions on the enforcement statistics provided? Seeing none, do we have any discussion from public in Garden Grove?
We do not, Chair Serpa.
Thank you. Moderator, we're ready for public comment for individuals participating via WebEx.
Thank you for our WebEx members that are joining our meeting today. If you'd like to comment on this item, you can raise your hand by clicking that hand raise icon at the bottom of your screen. Our mobile users can locate the ellipses to access the hand raise feature, or our call-in users can dial *3. And at this time, I'm not seeing any requests for comment, so I will return the floor to you.
Thank you, Shelley. Thank you, everyone. President O, I turn the meeting back over to you.
Thank you, Chair Serpa, always, and all the committee members. We are ready to start on agenda item 13, but we will take a quick bow break. So we will come back at 11:35. 11:35, it's 11:28. We'll return in short 7 minutes. We'll see you all back.
Yes, I'm here.
Yes, Trevor?
Present.
Thank you, Renee.
Present.
Thank you, Jeanette.
Present.
Thank you, KK.
Present.
Thank you, Claudia.
Present.
Thank you, Jay.
Present.
Thank you, Ricardo.
Here.
Thank you, Satinder.
Present.
Thank you, Maria.
Present.
Thank you, Nicole.
Present.
Thank you, and I'm here. Next agenda item is 13, Licensing Committee Report. As the chair of the Licensing Committee, I'm pleased to provide a report from the committee's meeting last month. As demonstrated in the meeting materials, the committee had a very long and productive meeting. As announced, we're extremely excited and grateful for the passage of AB 1503, our sunset bill. Lots to discuss. Thank you to my fellow committee members, Trevor Chandler, Renee Barker, Jesse Crowley, Claudia Mercado, and Satinder Sandhu. First, summary of presentations and discussion of pharmacy practice experience requirements pursuant to Business and Professions Code Section 4209. As the meeting materials reflect, pharmacy law establishes a requirement for an intern pharmacist to complete 1,500 hours of pharmacy practice experience before applying to take the pharmacist licensure examination. The statute further provides that an applicant that has graduated after January 1st, 2016, from an accredited College of Pharmacy is deemed to have satisfied the pharmacy practice experience requirement. The meeting materials also include information on the updated ACPE standards that all accredited pharmacy school programs must satisfy. This includes completion of introductory and advanced pharmacy practice experiences in pharmacy world known as IPP, APP, or IPI, or EPI, whatever they prefer. As noted during the committee meeting, the standards establish rotation requirements and require completion of a total of 1,740 hours of experience. Members of the board have received comments suggesting that the board should re-establish a requirement for an intern to complete internship hours outside of the practice experience gained as part of their pharmacy education. During the meeting, members received 3 presentations on this issue from Dr. Sarah McBain, Associate Dean from University of California, Irvine, Dr. James Scott, former Dean at Touro University, and Dr. Scott Takahashi, a pharmacist at Kaiser Permanente. I am hopeful members had an opportunity to review the live stream of the meeting. As both the live stream is available and the meeting materials provide summary information, I'm not going to review the presentations, but I do note that I found the presentations and varying perspectives very interesting. Following presentations, the committee discussed this issue. Committee members share their experience working as an intern, including myself, while progressing through pharmacy education. The committee considered if there is a potential means to incentivize rather than mandate pharmacy students to complete intern experience outside of their pharmacy education. As indicated in the meeting materials, the committee is not offering any recommendation, but is looking to the board for any recommendations or further direction from our members. Depending on our discussion today, the committee may schedule subsequent discussion. I do believe that the board could consider developing a policy statement and acknowledge that importance of gaining intern experience outside of APPEs or APPEs as one of potential means to convey the board's support to this additional experience without a mandate. I do not support mandate for myself, on my personal opinion at all, because I think that is going to be a very difficult way for us to navigate. The locations of pharmacy schools are very diverse. Some are in rural, some are in urban areas. So I think as much as possible to all students and interns that working outside of IPI and APPI experience, I just want to highlight that how important and valuable it is for our pharmacy students to work. So if there's any creative ways for our members, any suggestions would be welcome. But if at a minimum, we could develop a policy statement how the board strongly supports that endeavor. Members, any thoughts? Go ahead.
Yeah, I'll just say one of the things that was discussed at the meeting as rather than a mandate would be a potential certification that could be proactively pursued. So it's an if and rather than a mandate. So it could be an additional certification like ready to work in a clinical session. So I think there's ways to incentivize without mandating so that those who wish to pursue it can get the credit and recognition as part of their professional development. So I think there's some good ways we can pursue on this.
Thank you, Trevor. Jesse, your hand is raised. Go ahead.
Hi, thank you. I actually think that there should be a mandate, to be honest. I've been a preceptor basically since 2015, and the students that I see who work consistently are the ones who tend to be the most knowledgeable and the most prepared to go back into the workforce. Unfortunately, IPI and APPI alone, in my opinion, are not sufficient. It does not give you the hands-on experience of actually working in a pharmacy. And there are just some things you need hands-on experience for that you cannot learn from a test or from a book or just from a couple weeks on rotation. And so I actually would be supportive of a mandate. I'm curious how much of the non-work experience has anything to do with, you know, the decreasing passing rates for some of these exams. And I will say when I was an intern, granted, it was not in California, but it was a very competitive process to even get hired as an intern. And
almost all of the workplaces did have a minimum working requirement. So for me personally, in my district, it was a minimum of 8 hours a week if I wanted to retain work. I know at other workplaces that were more competitive, say you worked in a hospital, it may be even 16 hours a week. But those students were definitely more prepared to become pharmacists, to transition to that role, and also more prepared for their exams after graduation.
Thank you for the comment, Jesse. I do agree with you for sure, but I think it just gets very difficult in terms of, I think that overall during the meeting, what we highlighted is there's so many additional layers of factors involved in terms of the quality or maybe, of what's going on out there for exams and everything else in between. There's generational changes, attitude changes, quality of student pools. So many factors, and I think, if anything, we can continue this discussion, but I'm not sure if a mandate would be appropriate at this time. Any member thoughts? Renee, go ahead.
Yeah, I just wanted to make a comment. I would somewhat agree with Jesse in that. I mean, I absolutely agree, and our experience has been that the experience that they get from a rotation, or not rotation, sorry, not the IPPE or APPE, but from working basically as as an intern, is really valuable, again, to round out and to really solidify, and they see connections. So, I mean, with that said, I do think that with a mandate, it would be challenging for the number of students that are in California to find an intern position. I think there's not that many hospitals that hire any or very many. That could change right now. Like once they have that pool kind of dried up, once they were going to the year round, and the amount of time that they are available is much more limited. So their training is limited to what they can do at the hospital, in the hospital setting, my experience. But it is, again, very valuable. But I think I think there would be definitely, we get a lot of applicants, let's put it that way. So for our number of intern positions, which is not many, but we have a lot of applicants for those positions. And even so, it's not even close to all students looking for some. So, and I think it's just would be challenging because they have to be able to basically have that availability somewhere in a closer proximity to where they're living and going to school. But again, I would, I did my schooling here in California, and it was required at that time. And I feel like it was a challenge, but it was really worth the time. So I just wanted to add that.
Thank you, Renee. And I agree. I mean, every opportunity I get to talk to students, I tell them you need to work outside of, their school. So, I mean, I'm highly, highly encouraging. Maria, I'll go to you.
I wanted to just add to the discussion because I can see how complex and how this will require a lot of consideration because there is no easy answer. I agree with what we've heard, that the quality of students is not the same as it was in the past. And what is that? Is that generational? Is it because we're not requiring work? What is it? It's just different. But it requiring work may not be the answer because it's not that easy. It's not just one, it's a multifactorial issue, what's going on. But also the ability to have workplaces for all pharmacy students would be tremendously difficult. It was difficult in the past when we had fewer pharmacy schools. And I, knew people who would drive over an hour just to get to their workplace. And then also workplaces are not willing to hire people unless they're there to work. I mean, 8 hours is, you could spend several months training someone before they can actually even work. And by then they're not there for you unless you're looking for a person working for you that will be full-time after they get their degree or their licensure. That is probably not happening either. So I don't have the right answer. I think we need to have some further discussion. I don't think it should be something that's like bonus points if you work, but I also am not quite sure how you would mandate it. But there really is huge benefits to having more work type of experience. I don't think that that's possible. That's something that the schools could do, because in the rotations, the actual hands-on part of the work, in my experience, and of course I don't deal with that many students anymore. It's been the last about 5 years ago, probably the last time I dealt with some students, is very little hands-on, mostly clinical. And because of that, I think they've really lost some experience that I'm not sure how they can get back.
Thank you, Maria. So I'm guessing maybe let's hear from the public. I'm sure we have a couple people here. Oh, there. Yes, I was hoping maybe somebody from school would speak. So I know I'm sure Richard is not speaking on behalf of school. We're going to go to public comment and we'll continue our discussion and see where we're going to move forward on maybe potential solutions, if any. But we'll continue the discussion. So we're going to go to public comment in Sacramento. I'm sorry, we're not in Sacramento. I'm not moving around here. We're ready for public comment in Orange County.
Hi, Richard Ng, pharmacist and faculty at the University of Southern California, speaking on behalf of myself. I appreciate the discussion on this topic. There are very real issues around some workplace considerations and preparedness. However, I do agree with President O and many other board members that the return to the mandated 1,500 hours is not the answer to the problem that we are seeing today. I graduated from a California School of Pharmacy at the time when this was a requirement, so I went through that myself. I'm current faculty member now. I'm a preceptor for IPPI and APPIs. I'm a residency program director, and I train postgraduate residency pharmacists. So I definitely understand and agree with many of the comments that have been made. I think the comments from Maria and Renee about not enough positions is absolutely true. When I was a student, there were many students who couldn't get an internship job, and in order to be eligible for licensure, they had to sit out a year or two and then work afterwards, and that delayed their licensure, or they had to drive 1 or 2 hours to some other remote location that took away from their ability to study and prepare. Additionally, at the time when the 1,500 hours was required, the landscape for ACP requirements for schools of pharmacy were very different. The IPPI hours were not required. They were not standardized. Now they are at least 300 IPPI hours in addition to the APPE hours. There's a minimum required for all schools. So the number of experiential hours that's expected from schools of pharmacy has increased since pre-2016. Additionally, the didactic content that's required by ACP has also increased, which then means we have more didactic in classroom time. So while maybe pre-2016, the students had time to work 8, 16, 24 hours, they may not have that time to do that now, especially if they're in a curriculum where they have both class and IPPI happening at the same time in the same semester. So you have students who are going to class Monday to Friday, doing their experiential rotations, and some of them are working, and that's great. I tell all my students to work as well. But I think there's a lot of potential issues to the reinstatement of a mandated 1,500 hours that would just increase the burden on our students, our interns, our schools of pharmacy, our employers, and also on the board of pharmacy. If you'll recall, you had to have a lot of staff hours dedicated to verifying all of the intern forms that were submitted, calling employers, verifying hours, and I'm sure that reallocate a lot of resources that could have been spent on something else. Also, at the time, the intern hours were only applicable for students who are working in community and hospital settings. It did not recognize hours for those working in ambulatory care, pharmaceutical industry, or managed care. And many students are now working in those areas. And as we move to the standard of care model, you're going to want students who have those experience outside of hospitals and communities. So I appreciate the discussion, and I appreciate the committee's recommendation to explore other avenues and other ways to address the problem that we are seeing with some students and the generational differences, but the reinstatement of those hours and the mandated hours is not the answer. Thank you.
Thanks for the comments, Dr. Dang. Anyone else? Okay, we're ready for public comment in WebEx.
Commenters lining up. As a reminder, if you'd like to comment, please locate that hand icon, raise hand icon at the bottom of your screen. For our mobile users, you can access the prompt from your ellipses. And for our call-in users, you can dial *3. Our first comment comes from Brian Kawahara. Brian, I've sent you the request to unmute your microphone.
Good morning. Thank you very much for this opportunity. I tend to agree with what people are saying in terms of this is a pretty complex because I'm kind of split as to whether it's a good thing or not. I don't think having recently worked in an experiential area, the one thing that I do know that's a problem is that they don't get, in a lot of times, sterile compounding as something that they can do because of the um, mandates of 797 and the like. I think that's something that really hurts when they do go out to look for a job in a hospital. And I think it's important that we figure out some way to be able to get that type of experience to the students so they have an opportunity to go into hospitals with some kind of understanding of what sterile compounding is and what they have to do during it. In terms of finding jobs, it's even hard to find places to place students for hospital rotations that are mandated by a ACPE. So it'd be difficult to say, well, every pharmacy student has to go out and get a job. I think it's a good idea, but in terms of putting it into application, I don't know how easy it's going to be at this point in time. Thank you very much for your time, and I look forward to seeing how you approach this particular problem.
Thank you for the comments.
Our next comment comes from Chasney Johnson. Chasney, I've sent the request to unmute your microphone.
Hello, my name is Chasney Johnson, Pharmacy Technician 106559, located in Oceanside, California. Being a pharmacy technician, most of my experience has been in an inpatient pharmacy setting. Seeing students come in and having residency has been a pleasure, but some of the things that I do see as they come in is they're revamping roles that are already set in place, usually for a pharmacy technician. Some things that I would recommend or I would like to see is maybe being a teacher assistant in some like organic chem with real students who are trying to earn credits to go to school to be just like them. Being a pharmacy technician and going to class right after work or before work, students are not always taking the class as serious as it should be. So this would be a good example of just having somebody that just went through this whole process to be like a living example of like help you through the course and learning what you can be just by taking this course. And it would help like having teaching skills instead of automatically being placed into a management job position right out of residency. It kind of gives you a chance to learn and see the skills that their teacher just taught them. Thank you.
Thank you for the comments.
Next comment comes from Scott Takahashi. I've sent you a request to unmute.
Good morning, and thank you again for the opportunity to speak with the board and now with the license committee and now the board. Yeah, I presented a section just based on my experience as an instructor and preceptor. In response to some of the comments we just heard a second ago, IV compounding administration, I think that's an opportunity for ACPE to be petitioned to update its requirements or enhance its requirements to improve that as part of the required curriculum for graduates of schools of pharmacy and the PharmD programs. To address some of the issues related to the impact on pharmacy schools, I'm not sure if that's something the Board of Pharmacy needs to focus on. And it's not because we're being mean, it's just because we're the last stop to make sure that quality pharmacists are coming into the workplace. And there's sort of primarily supportive discussion of your personal experiences as pharmacy interns and as it relates to your experience in development as a pharmacist. But ACPE really has backed off from the accountability for the number of schools of pharmacy. Maybe California can't support 14 or 15 schools of pharmacy just because of the number of pharmacies that are actually active that actually take interns. And the other thing that's more generational, I think, that was discussed is that students are doing things we didn't do as interns. We didn't take a gap year. We didn't take vacations. We actually soaked up hours on our vacations. So If the Board of Pharmacy feels that the experience of internship hours is worthwhile and worth considering reincorporating into the requirements for licensure, I think that should be the guiding principle to make a decision, and that the impact on this number of schools of pharmacy may be self-limited already just by looking at the pass rates. It looks like we can only graduate about 1,100 candidates per academic year to pass the board exams coming out of California. That probably is indicative of the maximum number of students that can be engaged in the pharmacy curriculum. So again, I thank you very much for the opportunity to speak to the board, and I am speaking as an individual, RPH 42737.
Thank you, Dr. Takahashi. And again, thank you for the presentation you given during the committee hearing.
Our next comment comes from Nathan. Nathan, I've sent a request to unmute your microphone.
Hi, my name is Nathan Wadwani, and I'm a current P1 pharmacy student. I've noticed in our class, majority of the class actually wants to do internships. And the issue that we're having is just availability and barriers to entry. One is that, for example, I'm interested in clinical psych as well as informatics, and there's just I haven't found any internship opportunities yet. I also live in Oakland, so I'm pretty sure there's a high demand for psych services, and simply just getting connected to someone who's open for me to work with them flexibly to kind of learn the skills, I would love to do it, as well as more people in my class. So I don't know if the issue is really the requirement or not. I think it's just access, availability, and barriers of entry to really make it easy to start. And to be honest, the competitiveness and the application process, it's easier for me to keep my previous job that actually pays a lot more outside of pharmacy than it is to try and apply and get a role in it and work for lower pay as well. So just wanted to put that out there, that we'd really like to have internships, and if someone came to our school, made it easy for our interests that we're interested in and connected us, I think a lot of us would join it.
Thank you for the comments.
And our next comment comes from Sean Kim. Sean, I've sent the request to unmute your microphone.
Good afternoon, board. This is Sean Kim from California Pharmacists Association. CPHA appreciate the board's ongoing review of intern pharmacist practice experience requirement. CPHA also supports the ensuring graduates are practice ready upon entry to the profession. However, CPHA cautions against reinstating mandatory hours in lieu of incentives, as a mandate could create inequitable financial and logistical burdens, such as operational and administrative, particularly for students and schools and employers, and even for the Board of Pharmacy. Instead, CPHA encouraged the boards to explore incentive-based models that promote optional and practice-integrated experience, such as number one, recognition of the credit for the programs and the preceptors, paired with the high-quality educational standards and incentives for the preceptors to ensure consistent quality of experiential learning. This is broader systemic transformation that is required. Number two, partnership between the schools of pharmacy and the employers, acknowledging the operational lifts for the schools and the employers to create and sustain these opportunities. These points reflect not only CPHA's position, but also the collective inputs from the last week's California Pharmacy Council CPC meeting in San Diego. CPHA remains committed to working with the board and schools and preceptors and the practice sides to ensure the intern pharmacists to receive comprehensive, high-quality experiential education that builds the professionals' competence and readiness without imposing the operational barriers. Thank you so much for letting me comment.
Thank you for the comment, Sean.
And it looks like that is the last of our requests for comment. I will return the floor to you.
Thank you. Okay, members. Jesse, your hand is raised, so I'll go to you first, and then I'll check any other member comments, and we'll move on.
Thank you, President O. I really appreciate this discussion. I think this was great, and we heard from a wide range of people with great perspectives.
kind of thinking out loud on this because I know that there are huge barriers, especially if you have to go far. And echoing a little bit of what Dr. Sean Kim had mentioned, I think there needs to be some sort of incentive specifically for the pharmacist preceptor or possibly even the pharmacy itself to encourage pharmacies to actually hire more interns. I know this, and I will say I'm speaking from the retail perspective rather than the hospital because I know that may be a little different. But creating, I don't even know what that would look like, but if there was a way that we could create more incentives for the licensees, maybe that can help kind of bridge the gap there. I really also appreciate the intern hopping on this call. I know that's not as common, but it's a very important subject, and it's really great to hear from a pharmacy student with their perspective.
Thank you, Jesse. Maria?
I look forward to having further discussion about that. And so maybe there are some unique and interesting incentives to work. And one of the things that just came up the top of my head, and I'm not quite sure how this would work, but some sort of incentive like a decreased application fee if you have so many hours, or intern license fee. For some people that might make a difference. For others, it may be not worth the bother, but I still think some sort of discussions about incentives to work and maybe not mandated. I look forward to further discussion.
Thank you, Maria. All right. Any other member comments before we move on? Oh, Satinder, go ahead.
This is a great discussion. I love it. I think we all agree that more experience provides a better entry into the profession. So it's just figuring out, it's just problem how we solve this. And Maria, you just took it. I was just thinking along the same line in terms of incentive of like maybe lowering the fee for getting the pharmacist license. The other thing that I was thinking was, instead of focusing so much on the intern hours, and yes, we can have a policy to encourage them to get a job or get experience, but also, like some in the other professions, I'm thinking of doctors, they don't have a specific requirement that they need to be working. They have after they finish their education, they get certification in some ways, like they're board certified in this, board certified in various practice settings. So it could be an incentive for them to be within their first year of practice, whatever practice they choose, because there's when we say ready, there's so much a wide range of practice settings that these days available to the pharmacists. It could be for them to get a certification. It could be certification offered by, I'm just thinking, ACPE or CPHA or various different organizations. It could be employer-based, maybe something along those lines. So because our goal is they're competent pharmacists and they're ready, go into the profession, and then once they're there, they continue to be competent.
Thank you, Satinder. Any other member comments?
This is Renee. I think one comment I would have about that is I do think that once the students graduate, they are, sitting for the boards to get their license or licensing exam, and probably really needing to work since so many have student loans. So I don't think proposing anything post-graduation, I just don't see that people would kind of viably be able to do that. One discussion in the meeting was also that, there are students who probably could really it'd be helpful for them to earn money. It's not like they're earning a lot, the interns, but they're earning some. So we have had people who they just said they really need to work. So they, because the extra money helps. And I think just considering that, but not that the pharmacy school, I know they can't, that's not necessarily an incentive for them. The students have loans, but it's the reality for some students as a barrier. I just wanted to make a comment. I appreciate wanting to get sterile compounding experience, near and dear my heart, but I do feel that sometimes the interns Currently now, again, agree, there's not the training and qualification to be able to do that. And I mean, just to qualify to be able to be trained to do sterile compounding, and it's so many hours, they don't work enough. But I do think there are things that are very little more entry level that they observe all the functions and alongside pharmacists, seeing what pharmacists are doing. And I think that's the real value in that. So again, I wouldn't necessarily agree with a mandate, but if there was something close to a mandate-ish, that it would be a lot less hours. I mean, not talking about the 1,500 at all. So just going to add that.
Thank you, Renee. I know KK wanted to say something, seems like. Oh, and then Jeanette. Okay, we'll go to KK, then Jeanette.
Just a quick comment. I think it is vested interest of the profession itself to prepare the deeply knowledgeable next generation of pharmacists. However, we have to look into the economics of the businesses that can support the internship or training, because with current model, the staffing and labor requirement to run a pharmacy in any setup, long-term care, hospital, you name it, it's quite prohibitive to add more labor to that model. So yes, this is definitely needs to happen, but we also need to look at the economics that can facilitate that, so they can be interns or residents for longer and get deeper knowledge.
Thank you, Jeanette.
Oh, great conversation. So thank you, everybody. I would just hope that we, as we talk about this further, that we think of short-term and long-term solutions. And I really appreciate the public comment that the comment was systemic transformation. I think we need to look at institutional change in the long term.
Thank you, Jeanette. Anyone else before we move on? I will probably be able to say that we'll definitely have a policy statement. I think that's definitely a step. We'll look further into the continuing discussion if there's any ways to incentivize, and also just something that Maria said is very brilliant. We'll see how much of we can do, as well as maybe looking into but intern ratio that's currently in our statute. So many things we'll explore, but Jeanette, thanks for providing the perspectives of the short term and maybe long term, and perspectives of how we can, continue to discuss this matter. With that, we're ready to move on to our next. Man, I thought this was going to be quicker. You guys are good. I like it. Okay, so next, the biggie is now summary of discussion of changes in pharmacy law included in and proposed implementation activities regarding Assembly Bill 1503, Berman, Chapter 196, Statutes of 2025, including possible discussion and action to approve policy statements regarding transition of standard of care practice model, the role of the pharmacist in charge, and also to initiate rulemaking to add Section 1717.11 related to remote processing of prescriptions to California Code of Regulations Title 16. During the meeting, the committee dedicated significant time discussing recommended activities to implement the various and significant changes made in AB 1503, the board's sunset measure. Again, I'm just so excited and truly believe this will make so much improvement to patient care in the coming years. The meeting materials provide summary of the committee's discussion and public comment received, so I will keep my remarks for the various items brief as possible, because it's a lot of stuff. So starting with new section 4001.5 related to Pharmacy Technician Advisory Committee. I will need a lot of input from you all. The section now will require the board to establish an advisory committee to advise and make recommendations to the board on matters related to pharmacy technicians. The committee shall consist of four licensed pharmacy technicians representing a range of practice settings, 2 licensed pharmacists, one of whom shall be a member of the board. So it has to be one of our members who is a pharmacist and shall be appointed by the board president, and 1 public member. So total of 4, 5, 6, 7 members. As included in the meeting materials, the licensing committee recommends the board establish an online application process. Appointment terms will generally be 4 years, with the first appointments for some positions shortened to allow for staggered terms over the long term. The committee also recommends that the licensee appointments have at least 3 years of experience as either a pharmacist or pharmacy technician with a single employer. The application process should include 1 letter of intent along with 2 letters of recommendation and a CV or resume, hopefully not written by AI, please, for the love of God. Please, for the, we're just putting it out there. Well, it probably will be, but whatever. The pharmacy technician appointee should represent different pharmacy practice settings. You'll note that the board is seeking guidance from members on the appointment process. Should appointments to the PTAC, PTAG, we're going to figure out where it lands. Probably PTAG. I like that, but it's okay if you all disagree. PTAG. Other than appointment to the pharmacist member who is a member of the board and shall be appointed by the board president, it will be delegated maybe to 2 members of the board. Or does the board prefer that the board or committee of the board appoint members? If the board prefers either appointment by a committee or the full board, reminder that the process must be done in a public meeting, allowing the public participation and public comment. I do think this can be a little bit challenging, so I'm hoping for more flexibility. Maybe we can always revisit this issue in a year or 2, depending on how it goes. So I really do need some input from our members on how you all feel about this appointment process. I am very indifferent. We can look at 2-member volunteers for 1 seat kind of a way as well. I think that's a possibility. So anybody who would like to be engaged in this process, please volunteer and let us know, and we'll see what we can do. I know, Maria, your hand is raised, so I will go to you. Go ahead, Maria, and then I'll go to you, Jesse.
I'm supportive of this. Of course, it's something that the board needs to do. I would just encourage that we have spent some time on how we package this for informational, and that includes the name of the committee. I think the legislation has a name, but we need to look at existing committees either in the state or nationally that use PTAC as an acronym, or they were to use that. That's it. Thank you.
Thank you, Maria. Jesse?
Thank you, President. Oh, the one comment I had is in regards to the employment. So I know it said that licensed appointees shall have at least 3 years experience first from a single employer. I just want to clarify if we specified when that continuous work is, especially now considering all of the Rite Aid closures. I just want to make sure that if someone had previously worked for an employer, even recently for that chunk of time, that maybe recently changed due to things like pharmacy closures, that doesn't prohibit them from being able to be appointed. So I'm not sure if we actually clarified the work experience aspect, but I just want to be as flexible as possible for technicians who may be applying and do have significant experience.
Thank you, Jesse. Yes, I think that that's a flexible thing we could amend and change as necessary today. So members, please speak your minds today on this process. If you are indifferent, understandable, but nobody seems to have strong feelings on this. So Renee, go ahead.
Yeah, I mean, I would agree, some flexibility, perhaps a rewording of the 3 years of experience from a single employer. I mean, if if they get renamed, I suppose that's single employer, but I don't know, there's always circumstances that are hard to think of. At
Maybe
this moment.
single employer instead of single employer, like a single setting. Would that be more tolerable? Like if it's a community pharmacy, at least 3 years in a community pharmacy setting?
Yeah, I think to probably have
Would that be more
I
tolerable?
mean, if they had promotions
Or-
in there, it's regardless of
Okay.
their maybe there's still a technician in there, but what's their function? Like, do we, if they're being promoted in there, like that should be fine, of course. But I don't know if that fits into this wording. Just making sure.
Okay, and Satinder?
I was saying that it could be in the same setting because, people tend to move and they may go to a different employer, but they also, the experience be more recent, not somebody who's A tech a while ago, so.
Thank you. And then I'll go to you, Maria, then Nicole.
No.
Oh,
I'm
and I'll go to you after Jay.
Just
Go ahead,
wanted to
Maria.
add one thing. I think it's obvious, but I think it should be put in writing that the applicants be current California licensees in good standing.
Yes, that's absolutely. Thank you, Maria. And Nicole?
Just a clarification, sorry, I got confused when we were talking about the people, like board members being on the committee. The majority of the people on this are going to be technicians, right? It's just like
4
the
technicians, 2 pharmacists. 1 pharmacist will be someone that's not on the board, and the other pharmacist is someone on the board. So among 7 pharmacist members, one of you will have to volunteer, and please volunteer. And then 1 public member. My unclearness is that public member, I believe, can be a board member who's a public board member, can be that public member as well if you choose.
got
But
it. And so, and how many people are technician members? That's the piece I'm
4.
missing. Got
4.
it. Okay.
All right. Jay?
What's the intent of the original wording for having the 3 years under a single employer?
At the committee level, it is that we're hoping for people with relevant experiences, really who's practicing as pharmacy technicians, to be providing their insights of their daily jobs and responsibility, and how we could make that into workable kind of solutions, providing recommendation to the board. Someone who's not like in more of an administrative position, but more of someone who's on front lines, right? Kind of that thinking.
Okay, so much like what Satinder said, if there's not a disruption in terms of the learning process or the specific field that they're going into within pharmacy, there's nothing that disrupts that intent for them to go from one place to another. Is that correct?
Seems to be, if we're going with a setting, right? Similar setting. Yeah.
Yes, I would definitely just push for them to be in the same setting.
Thank you. And Jesse?
So I'm a little on the fence, honestly, about the setting. I think that it makes the most sense for the positions that are specific to that setting. For example, in community, of course, it makes sense that the 3 years experience has to be in community. Same with hospital, but for the unspecified seats, I don't know that the setting holds as much weight of importance. But with all that being said, I trust that whoever's going through these applications will use their best judgment. And so I pass that evaluation really onto them. For me, it doesn't make it as much of a difference, but
Oh, well, I mean, we can also look at it for the 2 unassigned category seats. We do not require that single setting either. So again, remember, board, this is a very flexible. The statute was not as clear in what we do, so we kind of have some discretion on how we want to move forward.
This is Renee. I just feel like there should be at least some consistency about the requirements.
Okay.
So, to have require a minimum of 3 years for 2 positions, but the other ones not so much. I mean, I do think that there's a certain amount of mastery that comes with time. So, I mean, 3 years would be the minimum. I mean, where you don't, because it takes a while in any position, pharmacist or technician, but where you're learning like what you need to do, but you learn the interconnectedness, and then you learn how to do like process improvement, or so I think somebody would need to be in that somewhat frame of mind to know
Yep.
how like a little their position more globally, and how it fits into like as a larger profession, so that because they're going to be having impact, right? So I do think that minimum of 3 years should
Yes.
apply to everybody.
Okay.
What those other 2 positions are, since it's not specified, but I still think they should have some mastery in it.
Sounds
So I
good,
think the
Jay.
3 years.
Yeah, unfortunately, I'm a public member, so I don't know how the internships work so much. Are there learning agreements that are created when they do the internships, regardless of how?
Technicians?
Yeah.
I think in technicians, usually the way it works would be that they know what job they're signing up for when they're applying for jobs, so that sometimes it's based on what kind of jobs they're in.
Hence the
How-
setting, right?
setting, yes.
Okay,
So
so-
like someone who was working at Rite Aid And so unfortunately, Rite Aid is no more in this world. So you, in that community setting, most likely you're in a community pharmacy setting. So then that person can go work for Vons, and that person's, maybe accumulative experiences in a community pharmacy is, right, 3 years, but that the job duties in a community pharmacy is pretty consistent
And are those written out, or is that
in their
just
job description.
okay?
Yeah.
That's what I was. That's kind of
So
the
should
thing.
we then require job description of their job? I mean,
I don't know if you can, but maybe,
yeah.
I mean, if that's possible, it seems like
We'll
at
have
some
to
level
rely on
some of
their-
this should be standardized and the other parts are nuanced because you're, with different employers, but
Yeah.
it feels like there's certain tenets that that you're going to have to learn regardless of what type of setting it is. For this setting, you need to know these 300 things intricately. For that setting, you need to know these 200 things intricately. So it just seems like I don't know how standardized or not standardized that is at present. Yeah, that look tells me a lot.
Probably not as standardized. Yeah. Okay, members. I do need help though in appointment process because that's the more difficult. So, okay, so I think we're kind of getting with the 3 years single setting for 4 technicians. I think that's where we're landing in terms of just the discussions. We do need to figure out the appointment process because that's where we did not have, as a committee, we did not have any strong feelings. We really didn't have any strong ways, desires on how we want to go. So I think one seat, pharmacist board member seat, is very clear that it's appointed by the president, but the other 6 seats are a little unclear. So other than the application process, so need some help here. So Maria, I'm hoping you have some magic bullet.
Well, I don't have
Magic
any
answers?
magic bullets, but I know the state is very, very specific about all sorts of things. And so my questions would be, what needs to go through HR, the appointment process, the who appoints and how, and are they, how are they termed? Is this I don't know what the state's requirements are for ad hoc committees versus ongoing committees. And, like all of us as board members, we get lots of stuff about not CE, but whatever it's called.
Requirement,
All
training,
those
training
things that we
requirements.
need to do and sign and fill, and because
Yep.
we're pseudo employees. So I think there's a lot of questions there that whatever's legally required, and then you could develop probably a subcommittee, or we could vote on it as a committee in closed session or something.
Okay. Go ahead.
So I'm not quite sure closed session is an option because the government code details out what the board can meet in closed session on.
That is correct.
So what kind of private thing could we do to review the applications? I mean, we certainly don't want to put the applications in a public meeting.
That's the decision making. We may have to if we go with one. So I'm thinking, I don't know where our members are on this, but I'm thinking at least at the beginning, like, so reminder that if we have 2 members deciding on one person, that could be done in a more of a not open meeting setting. So maybe there's 4 seats of public pharmacy technicians. Maybe each members, 2 of them can be assigned for each seat for appointment process at the first run about it and see how that goes. For example, I could team up with Jesse and I would be assigning that. I could team up with Jesse, Maria can team up with Claudia, or we could do pharmacist public member thing and just kind of go through the applications of that one member position for the technician member and then kind of go from there so that we have flexibility in terms of appointment, also transparency. So it's not just one person deciding, it's the board decision in a way, and kind of looking at that way. So I'm just throwing that out there. Jesse?
I was actually going to suggest something similar, just dividing it up with 2 members selecting it. I don't know if do we have enough members to do that 6 times? I guess that's
Well,
my
it would
first
be,
question.
yeah, it would be really 5, 6, I guess. Yeah. In theory,
Yeah,
yes.
I guess it would be 5 members. I think that's a good idea rather than having it be public, truthfully, because of some sensitive information that may be in some of the applications. I wouldn't necessarily want that in a public setting, but I would be on board with that.
And then I would also be okay with the president kind of dividing the board up to go through applicants.
And the members who's deciding, right? Okay.
Yes.
Maria, go ahead. You're muted, Maria. Muted, Maria.
Talking to myself. One of the challenges with that is if someone were to apply to be a community technician and it were filled by another, they would still be able to be the unspecified position. You know, so I'm not quite sure how that would work. You know, the unspecified position could be a community tech or could be a hospital tech. So they should be able to apply for both. I know.
Oh, I see. Well, maybe there's a clearinghouse so that if there is a like you're a community. I mean, the intent of it is so that to get the diverse experience. So I would hope that there are different settings that technicians would apply so that if you're a community pharmacy technician, you would at first would apply to a community pharmacy technician seats.
So then you
So
have
that
to be clear, I think, to say unspecified, not including community or hospital. Otherwise, the way the board works, you know, for our board members, we have some seats that are kind of unspecified, and they could be a long-term care, they could be a hospital, they could be
yeah.
one of the others.
Yep. Members, what do you think of the idea?
Um, I guess does it not seem that those two unspecified practice positions are not community and hospital since they're not specified? So in other words, we don't have one or more positions representing community, one or more. Do you see what I'm saying? Like I mean, I feel like the variety is going to be really important. There's a lot of technicians doing a lot of different things. So, you know, I think it would be important. It's not specified,
Yeah.
but I think it's important that we have like closed door pharmacy, long-term care facilities, you know.
So we need to specify that non-specific setting is not for community pharmacy technicians, right?
Yeah.
Yeah.
Nor hospital. right?
Korean? Corinne.
Yeah, sorry, I was
Did I just call Corinne Korean? I'm sorry, Corinne.
It's okay, you got it. Just to clarify, in case there was any confusion for the members, I mean, what the statute says is representing for the tech positions, the 4 tech positions, representing a range of practice settings to provide a diversity of perspectives. So the statute itself does not say you have to have a community pharmacy person. So that's, you know, the board's discretion to decide how you want to, you know, reflect the range of practice settings.
Thank you, Corinne. Jesse?
Thank you. I think that that actually helped to clarify some things, but I think part of the issue is at this point we don't know the practice settings that technicians applying are going to be from, and so we do run the risk of maybe there isn't a long-term care technician who does apply. I mean, I really hope that we do get a wide range of technicians. But if we do get to a point where we don't have as wide of a range of settings to choose from, it may be better to leave those 2 open-ended and give us more flexibility.
Go ahead, Trevor.
But then
Okay,
that becomes a bigger issue because then I think we would have to continue this discussion more in like a public forum.
Yeah. Thank you, Jesse. Go ahead.
Yeah, going off of what Jesse said as I listen, the conversation is based on the assumption we're going to have a robust applicant pool, which I hope we do. But in my experience with setting up committees like this, especially as we raise awareness of it, I don't think we should overcomplicate it right away. I think we should just focus on getting it set up, getting people on it, in an expedited fashion, and then figuring out being a little bit more prescriptive and deliberate in the appointments after that. I mean, so that's just my personal experience on setting up kind of committees like this that might not have the same visibility is don't overcomplicate, get competent people that apply on, and then as it matures as a committee, being much more specifically intentional about process and specific slots. So that's just my contribution.
Thank you, Trevor. Maria?
I agree with everyone, but I'm just looking at the logistics, because if I'm applying and I click the community tech and you pick somebody else, that means I haven't applied for the unspecified. So there just needs to be some logistics so that those applicants for community and hospital are also considered for the unspecified, or some manner that you don't apply for one and then are no longer qualified for the other.
Got it. Thank you. Jesse?
Is there a possibility that, we put this application online, we just have one application to fill out, and then maybe we encourage people in the letter of intent to specify what position they're trying to fill, and that way we make it a little more open for the applicant themselves, and maybe once we receive the applicant, all of the applications that deadline closes, we may be able to meet or present at the board meeting the kind of settings that are there, and then revisit this conversation once we actually have the applications in before we divide it up.
Okay. Thank you, Jesse.
This is Renee. I just wanted, so I would agree with something like that, a very general, not people necessarily putting themselves into that. I think some of how to get the variety might be in how the messaging goes out. Unfrequently, maybe for technicians, and trying to make sure that all the settings are informed, something like that. That we're really looking for a wide range, so that somebody feels that even though they may not be the large pool of community techs, community pharmacy techs, that they could still apply and their input would be valuable, just so they understand that.
Thank you, Renee. All right, members.
I'm sorry. I
ahead, Jenna.
would also add, as someone who worked in the appointments process, that this will be an ongoing process.
Yes.
Consistently recruit people, and I would agree with both members about keeping it general, and Trevor about working to manicure the process after we have our first shot out. The other thing I would ask is, are the farm techs going to be compensated even a tiny bit for their time? I mean, I'm just being the
Not
reality
sure.
of the.
We'll have to examine that from. We don't know the answer.
Oh, okay. Thank you.
It's kind of an uncharted territory for us, just so we're all clear here. That's why we're like this is a fun discussion. Okay, so I propose maybe we have a committee of 2 members who will be assigned by the board president, maybe for 2 technician members, another committee of 2 for another 2 technician members, committee of 2 for 1 pharmacist application, and another committee of 2 for public member. Does that make sense? I think that's where we're going to start. And then we'll go from there. I'm going to take the silence as an agreement. Okay. We'll start there. I hope that gives a direction. Corinne, the only thing that I wasn't sure is, do we need a motion here? Because I feel unclear.
I think when in doubt, make a motion. There's no
Okay.
harm in making a motion.
All right. So with what I laid out, I'm just gonna make it easy. So I'll make a motion. That's the process, and then just encompassing all the others, which was at this point probably best to do the community pharmacy technician member, hospital inpatient pharmacy technician member. 2 are unspecified members. 3 are single setting experience. Stagger terms, which will be determined. Committee of 2 board members assigned by the board president. For basically, there will be 1, 2, 3, 4 committees. And to clear that, if anything, the committee also forgot the part is the board has the ability to remove a member from the PTAC independent of a term expiration. So the board can vote to remove a member if necessary. So hopefully that's enough.
The only thing I would clarify is it sounded like you were specifying positions for the text. I mean, is that consistent with what the board, the consensus of the board? Because I also heard people saying leave it general.
Okay, so do we, okay, I'm not sure where we landed on that. I heard two mixing things. So Jesse, go ahead.
My impression or in my opinion is that at least those two seats, like for sure, community and hospital should be represented, and then leaving the last two seats open. I'm in agreement with the committee's discussion on that.
Okay. All right. Are we clear on the motion, members? I hope. I'm sorry, this was a little bit of a discussion with a little no direction, so sorry for that. Okay. Do we have second?
I'll second.
Thank you, Satinder. Okay, public comment in person. Seeing none. Ready for public comment in WebEx?
For our WebEx attendees, if you'd like to make a comment on this item, please use that hand raise icon that you can find at the bottom of your screen. For our mobile users, you can find the prompt under the ellipses. And for our calling users, you can dial *3. Our first comment comes from Chasney Johnson. And Chasney, I've sent the request to unmute your microphone.
Hello, my name is Chasney Johnson, Technician 106559, located in Oceanside, California. Being part of the Pharmacy Technician Advisory with the California State Board of Pharmacy, will there be a chance for a promotion to be a pharmacy technician and be able to attend regular board meetings? Because just listening and watching other states, for example, Nevada, pharmacy technicians are given a microphone to just say anything. And if we are given a chance to learn basic techniques, whether that's taking notes or being the moderator, you will be able to try out or apply to other community board meetings within your city. And that would be my feedback for today's agenda. Thank you.
Thank you for the comments.
And our next comment comes from Sean Kim. Sean, I've sent the request to unmute your microphone.
Good afternoon, board. Sean Kim from CPHA. First of all, CPHA applauds the board's successful efforts to advancing the Sunset Bill AB 1503, including the establishment of Pharmacy Technician Advisory Committee, PTAC, under Section 4001.5, which recognizes the essential and evolving role of pharmacy technicians in patient care. Pharmacy technicians are a vital engine of pharmacy, without doubt. CPHA supports the proposed committee structure and staggered 4-year terms, which will help maintain the continuity and ensure the representation across all practice settings. We also support the inclusion of the board pharmacist member to ensure the strong alignment between pharmacy technician perspective and regulatory priorities. Before appointing the committee members, CPHA encourages the board to clearly define and publicly communicate PTAC's roles and responsibilities so applicants fully understand their expectations. For instance, CPHA encourages them to assess workforce needs, such as Community Health Worker Certificate Program, which is called by the CMS Rural Health Transformation Program, continuing professional development, expanded scope, and integration of the clinical workforce workflow to be aligned with the standard of care regulatory model under AB 1503. As the appointment process proceeds, CPHA also recommends including the competency-based selection approach. Beyond the years of experience, please consider leadership education, precepting, training experience so members brings the both practical and strategic perspectives. CPHA is committed to collaborating with the board to promote the growth and the professional advancement of California's pharmacy technician workforce. We look forward to contributing this process and helping ensure the PTAC strengthens quality, competency, and collaboration across the profession. Thank you for letting me comments today.
Thanks for the comments, Dr. Kim.
Next comment comes from Rachel. Rachel, I've sent you the request to unmute your microphone. Rachel, you should see a button pop up on your end. Okay, I see you're unmuted now.
It just took me a few minutes. Rachel Miller, pharmacy technician, license number 17. Gosh, I just had it. Sorry.
It's okay. You don't have to
Okay.
say your license number.
I was just following along what everyone else is doing. Anyways, I'm asking for some maybe clarification. You're saying 3 years in a setting for the community and hospital. As a pharmacy technician that is not currently working in a maybe standard pharmacy technician position, would the other 2 seats also require 3 years in a pharmacy setting, or something else, if that makes sense?
Thanks for the comments.
Thank you. And our next comment comes from Cynthia Bennett. Cynthia, I've sent the request to unmute your microphone. And Cynthia, you should see an unmute me button pop up on your side that you will need to click to unmute your microphone. If you're connected by phone and computer with them linked together, you'll need to make sure both are unmuted. All right, I'm not seeing Cynthia's microphone unmuting, so she may be having some challenges with that feature.
We'll have to move on, Shelley. We're very
Okay.
pressed for time, so we'll return if we can get her audio back.
Okay, and with that, that's our last request for comment.
Thank you so much. Okay, just for clarification, I believe the expectation of where we landed is that community pharmacy and hospital pharmacy setting is appropriate, but the other 2, it's still the expectation that the single consistent setting experience of the 3 years. So for someone who's been in sterile compounding for 3 years, that would be kind of an experience that we would be expected, or some kind of an experience in a prior authorization, long-term care, 3 years in that setting would be appropriate. But again, we're not going to get this perfect right out of the gate. So we're just this will be a work in progress for us as we navigate this process and this committee. Members, before we call for vote, do we have any lasting comments? Ready for vote? Oh, okay. So, all right, Jesse, how do you vote?
Yes.
Thank you, Trevor.
Yes.
Thank you, Renee.
Yes.
Thank you, Jeanette.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you, and I vote yes. Okay, members, so I'm being told that lunch is here, so we're going to take a lunch break. We'll come back at 1:30 p.m. And continue this discussion. We'll see you all back at 1:30. Enjoy